It's a purchase my card. Oh, I have. Somehow from the side. This is my old plan.
Hello, hello, mic test. Hello, hello. Good morning, ladies and gentlemen. I'm Bhavna from Amtron, your host for the event. On behalf of NIHFW and Amtron, we extend a warm welcome to all distinguished guests attending the National Consultation on Adoption of Industry 4.0 powered digital health solution to address SDG 2030 gaps in northeastern states at NIHFW New Delhi. The event is the beginning of series of efforts by NIHFW to adopt Industry 4.0 to address the medical education and healthcare access in northeastern region. So now I request all the esteemed dignitaries to grace the stage. Sir, please, sir, ma'am. A big hand for everyone. Thank you so much, everyone. Now, let us begin this auspicious occasion with the traditional lighting of the lamp. I invite Dr. Loro Fose, ex-Vice Chairman, Northeast MPs Forum, and Shri Madhukar Kumar Bhagat, Joint Secretary E-Health, Ministry of Health and Family Welfare, Government of India, and Ms. Reena Assis Taj, Director E-Health, Ministry of Health and Family Welfare, Government of India, to kindly do the honors. Thank you so much, everyone. Now let's move to the facilitation ceremony. May I please ask Dr. V.K. Tiwari, Dean, NIHFW, to facilitate our chief guest, Dr. Loro S. Fose. Everyone, please, a big hand. Thank you so much. Next, may I please ask Anand sir to please facilitate Shri Madhukar Kumar Bhagat, Joint Secretary E-Health, Ministry of Health and Family Welfare. Thank you so much. Now, I please ask Dr. Dharmendra Kumar Yadav to facilitate Ms. Reena Ashish Das, Director E-Health, Ministry of Health and Family Welfare. Thank you so much. Now, I please ask Dr. Thank you so much. Now, can I please ask Ashish Anandji from Amtron to please facilitate Dr. D.K. Tiwari. Thank you, sir. Thank you so much. Now, it's my pleasure to invite Dr. V.K. Tiwari, Dean, NIHFW, to deliver welcome address. Dr. Tiwari's guidance and leadership have been pivotal in shaping this initiative. Sir, the floor is yours.
Respected Dr. Professor, the chief guest of today's function, Shri Madhukar sir, Joint Secretary, Ministry of Health and Family Welfare, is the guest of honor, and Madam Director E-Health, Madam Reena Das, ma'am, and Ashish sir, and Dr. Dharmendra, very good, and dear delegates and senior officials from the ministry and other experts and participants of this stakeholder workshop. So, very good morning to all of you. I welcome all of you on behalf of faculty, director, and staff of National Institute of Health and Family Welfare. I welcome you in this green, lush green campus of the National Institute of Health and Family Welfare. Some of you may not be fully aware about this institute, so I would like to take one time to tell about my institute. This institute is almost half a century old institute, almost 50 years we are going to complete. And this institute is involved in engaging teaching, training, and research activities, and also act as a brain a think tank for the Ministry of Health and Family Welfare. We offer a PhD program in public health. We have 3 years MD in Community Health Administration program affiliated with the Faculty of Medical Sciences, University of Delhi. We have 2-year Diploma in Health Administration program. Again, it is affiliated with the Faculty of Medical Sciences, University of Delhi, and these two courses are NMC approved courses. We have the Masters in Public Health program, 2-year program, affiliated to Faculty of Medical Sciences, University of Delhi. And our PhD program is affiliated to, it is jointly organized with the Jawaharlal Nehru University. And we have 6 distance learning courses conducted for last 20 years, over 2 decades in the institute. Again, this institute is very important for the ministry because we are designated as a national training institute by the Ministry of Health and Family Affairs. And this institute conducts many training activities for the Ministry of Health and Family Affairs. But on our own, we also conduct around 100 training courses and workshops, etc., in a year, and more than 3,000 participants last year and last few years, around 3,000 participants. They have participated in various training activities. We have certain verticals also which are very important. It is a collaboration between Ministry of Health and Family Welfare and NHW. For example, one is we have the National Center for Vaccine Management Resource Center (NCC) in Nasi, and now proposal is to upgrade up to international level. Already this center is involved in international training and capacity building. We have Center for Health Informatics under e-health division, and that's playing a very crucial role in development of digital and e-health activities in this country. And we have Saksham portal also. Dr. Dharmendra ji, he is managing on behalf of our ministry. We are really grateful to Honorable Minister of Health and Family Welfare and Union Health Secretary sir, that they have assigned this responsibility of managing Saksham portal with the help of e-health division and other senior officials of the ministry. So these three very important uh, uh, verticals are also um, working at the institute. And this institute is again, being the think tank of the think tank for the ministry. We are also taking out of the research activities, research and evaluation activities. Recently, we are involved in NACO Phase 5 evaluation of the HIV/AIDS control program in this country, and five national health programs are also being evaluated on behalf of the NCDC. So there are many activities, and around 100 students are participating various academic activities. And this program, this national consultation on adoption of Industry 4.0 powered digital health solution to address SDG 2030 gaps in northeastern states. So this is a very important activity, and I think 6 months back, Dr. Dharmendra ji, he is very dynamic faculty member of this institute, and he is a key person behind signing MOU between the AMTRON and NIHW. So NIHW has lot of expertise in organizing training program, extramural mode, intramural mode, in the e-health mode. So we have the a good capacity of handling such a kind of the collaborative training activities. I have seen this program, this consultation, this program, and I hope this is a well designed program. I hope this kind of this consultation and recommendations during the very deliberation made during this consultation, and at the end of this consultation, some recommendation made will be very useful to take our MOU with them, take it forward for thinking about the newer kind of the activities and whatever the planned activities to conduct those planned activities in a efficient manner and in an effective manner. So I congratulate the organizers of this consultation, this workshop for uh, for this very useful activity, and I hope this all of you will enjoy the hospitality of the NISW, our green environment, and whatever the best possible way we can do this stakeholder workshop. We will try our best to organize this workshop. I welcome you all, and I express my gratitude to Chief Guest Rose Sir, Director E-Health Madam, and then Joint Secretary Sir, and Dr. Anandji uh, for deciding to organize this stakeholder workshop at the NISW, and I wish a big success, grand success to this activity. Thank you very much.
Thank you, sir, for your warm welcome and inspiring address. Your words have set the perfect tone for today's workshop, and we deeply value your insights and support. So now, it is our privilege to welcome Shri Madhukar Kumar Bhagat, Joint Secretary E-Health, Ministry of Health and Family Welfare, as our esteemed speaker. Sir, your work in e-health serves as a cornerstone for modern healthcare transformation. We look forward to your address. Thank you so much.
Respected Dr. Loro, esteemed guests on the dais, Dr. Yadav, Dr. Tiwari, Veena ji, and all of the esteemed guests who are present over here. Welcome to this two-day capacity building workshop. It's a cold day in Delhi, and those who are non-Delhiites may be feeling the chill. Thankfully, the room is warm, it's pleasant, it's cozy, and it's a small gathering where we can more comfortably discuss what are the challenges and how do we take forward this initiative which is developing over here. So Northeast is a very special region of the country, which is replete with natural resources, great culture, very ancient history, and of course, very rich human resource. To add value to it, what do we do so that the real potential of the region can be realized in all the domains, whether it is economy, whether it is ecology, whether it's culture, whether it's development, or whether it is any other field, be it sports or any other field. Presently, we are talking about the field of medicine, the field of technology, and this is an initiative for capacity building, of sharing our thoughts and taking this initiative forward. If I have to have a look at the field of medicine, then I often tell about the four pillars, the fundamental aspects, and these pillars serve to us as also the touchstones. These pillars are whatever am I doing, how it is impacting the first touchstone, the first pillar, which is of availability of medicine. Second is accessibility of medicine. Third is affordability of medicine. And the fourth, a very important one, is the quality. Now, India has its own set of problems. If I see towards West, then the per 10,000 patients, we have a doctor to patient ratio of 34 to 10,000. And India typically drops down to 7. And that is also largely concentrated in the urban areas, cities like Delhi, or maybe in the state capitals like Guwahati. But if I move forward away from these, go to the districts and go to the rural areas, then there is a huge challenge. And therefore, it is not just availability, but it is also accessibility, especially in the domain of Northeast. I mean, just now we were talking about how many lakhs of workers in the oil field, in the tea industry. And we have to think whether medicine is actually available to them. And if it is available, how can they access it? And then comes the other questions of affordability. Of course, the government of India, through its PMJ program, Ayushman Bharat, it has done wonderful because it is providing an insurance cover that, okay, you don't have the money, at least the government comes and pays the coverage of 70-year-old population is a big help that way also. I remember going to AIIMS Delhi and seeing earlier families which were languishing for treatment of their elderly, for cancer, for months, selling off their family silver or assets or businesses, closing down and coming over here. And that is the question of affordability. But then the question of quality still remains. If I go to a rural area, there is a PHC which is available, but is all quality treatment which is desirable for the treatment of medicine available over there? Otherwise, again, the rural to urban migration starts kicking in. Earlier, that migration took place because of work opportunities, because of education, for entertainment, as well as for medicine. But if we don't take care of all these elements, then again the rural to urban migration will keep on kicking in. There will be deficit in the rural areas. And when I say rural, I mean non-urban areas, which are not really connected to the big cities. So how do we fight the challenge? Technology has come in a big way. Medical technology is helping us. I see in the brochure, the 2-day program, that quite a few wonderful areas have been covered by the organizers, and I must congratulate you. And some of the areas which I would further like to highlight to complement or maybe to supplement as to your thoughts will be areas like electronic health records and data standards. Now, Government of India's initiatives in EHR and HMIS is pertaining to the e-hospital, which is an NIC product, and then we have the next gen of NIC. And a lot of hospitals, so I'm told NIC told me more than 500 hospitals of Northeast region have already adopted e-hospital and they're supporting it. There will be challenges and inputs regarding further improvement will always be welcome. A very fundamental thing of any database management system, hospital management, resource management system is the identity management. And therefore, government has come up with a plan of using ABHA ABHA as the identity. And therefore, for the hospitals, it is very important that we sensitize that ABHA needs to be populated. Because unless you populate ABHA, the interoperability does not occur. That is the fundamental of interoperability. The records which is created based on the UHID cannot be transferred from one health system to another health system. And therefore, populating the ABHA in all the hospital records is extremely important. And therefore, there should be due sensitization of the health workers, of the industry, of the hospital management towards this critical aspect, a fundamental aspect, that unless you have the interoperability, you will not reap the benefit of technology. You will still have their same old patients taking out their digital records, taking out the printouts of those digital records and giving it to the doctors. And the data which is flowing from various federated architecture as we have devised will not eventually get integrated. Typically for a region like Northeast, where accessibility is such a challenge, having worked in railway, I always used to draw my past from Dibrugarh, right? So Dibrugarh remains very close to us because that was the last railhead of the railways. And therefore the railway class in, I'm talking about 25 years ago, used to from Dibrugarh to Kanyakumari or Dibrugarh to Gandhinagar. So it's transcending the length and breadth of the country. And therefore, despite Dibrugarh, we still have beyond that a large portion which is not covered by rails. Sir, if I'm right, given your experience. And how do you even cover that area which cannot be physically transcended, which cannot be physically covered? And therein comes the question of use of areas like telemedicine. So e-Sanjeevani technology helps us in a big way. In India, the e-Sanjeevani platform of Government of India, Ministry of Health, has afforded treatment to almost 31 crore people, 31 crore patients. And every day almost we receive 3 lakhs to 6 lakh calls, which are pertaining to treatment. And again, if there is a sensitization as to taking further the telemedicine initiatives. Presently, it is built in the PHCs and the CHCs, and it can even go beyond that. It is based on the hub and the spoke model. It can be based on even the mobile van models. And these are some of the areas which can help Northeast region facing its unique challenges to offer unique solutions. We have other initiatives, whether it is the artificial intelligence, and we are heading a program on artificial intelligence for detection of cancers, typically oral cancer. And especially in Northeast, I'm told that oral cancer, it is a particular issue because of, I think, areca nut chewing and other betel nut and other issues, which is less in the different parts of the country and almost unheard of in other parts of the world. And therefore, each region has its own health problems. And as a technology, we have to come forward and find solution to it. There are several initiatives, and one of the important planks is Saksham. Saksham is a plank where we are merging, bringing the confluence of technology and capacity building. We are uploading content for the purposes of training. I mentioned that India lacks doctors. And to train doctors requires the physical infrastructure, the medical and dental colleges, requires curriculum, requires teachers. The vision of the Ministry of the Health Minister of the Prime Minister is that through digital initiatives, if we are able to build capacity for training, for learning, then that is what really augments our human resource. Let me end with a last quip from a completely different area of economics. Around 150 years ago, Schumpeter, a famous economist, told that there are not just two factors of production, which was conventionally understood, which is the labor and the capital, but there is the third and the very important factor of production. And what he says not only rings a bell, but finds acceptance and finds utility and finds relevance increasingly today. And he says the third factor of production is technology. And that third factor of production, technology, means innovation, bringing more areas, bringing more resources. The conventional technology that we think in form of engineering and scientific technology. And in that technology is also an area of augmenting our capacities. So when we talk about areas like technology, capacity development, and Saksham portal, then we have a possibility of bringing return to scale, which is multifold. So let me finally end with the shlok from our Upanishads, which says, Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu, ma kasyat bhakave. Thank you.
Thank you, sir, for your enlightening speech. Your vision for technology with healthcare is truly inspiring and provides a strong direction for our efforts. Now, next, we have the honor of inviting Ms. Reena Ashish Dash, Director e-Health, Ministry of Health and Family Welfare, to share her perspective on this initiative. Ms. Dash's expertise in driving e-Health initiative has been exemplary, and we eagerly wait for her insight.
Good morning, everyone. And actually, sir has covered the topic uh, at a very vast length, and I don't think that I have much to say. But I would add on that as sir has highlighted many of the projects which Ministry of Health is running, and mostly I'm taking care of the digital health project, so I can only talk about those. We are trying to uh, use the technology to take care of the healthcare sector. And sir has mentioned about e-Sanjeevani. It's a very innovative as well as a very promising program. And we want to highlight some of the points that we just want to create a lot of awareness about it, because I feel that not many of the patient in the remote or other areas, they are aware about this program that Government of India is running such telemedicine services. So our agenda is to highlight or to create awareness that many patients which do not have the capacity to travel beyond a certain point to take the to reach the health facilities, so they can take help of these services, because a lot of doctors, health service providers are associated and giving useful and advices through these telemedicine services, because it's a pan India network, and it's a very big chain. So we can definitely work in that area. And as Saksham sir has pointed out, Dr. Dharmendra is taking care of. That is also so many clinical courses and tutorials are available. So I would like to share that everyone should go to the site and they can teach themselves and get a lot of knowledge through those portals as well. So just it's a request that you must visit the Ministry of Health site, because a lot of programs and digital health initiatives are there. So you must have a look at it and please go through it so that just get an acquaintance about the programs which Ministry of Health is running. And sir has rightly pointed out that through technology we can reach to the last person also. So my best wishes to to NIHFW team and Mr. Yadav in particular. So and best wishes for the program. Thank you so much.
Thank you, ma'am, for your thoughtful and impactful speech. Your words have enforced the significance of e-health in addressing the challenges faced by healthcare systems today. So finally, we are privileged to have Dr. Loro S. Bose, ex-Vice Chairman of Northeast MPs Forum, with us today. So he is distinguished leader and a dedicated public servant, representing the voices of people with unwavering commitment. Born in serene landscape of Northeast India, he has consistently worked to uplift the marginalized and advocate for justice. A visionary politician, he has also contributed immensely to the socio-political development of his region. With a deep understanding of empowered countless communities, his relentless efforts in education, healthcare, and infrastructure have brought transformative changes, a true champion of peace and harmony. His leadership inspires countless individuals. His ability to unite diverse groups under a common goal is commendable. Known for his humility and wisdom, he continues to set benchmarks in governance. Indeed, it would take endless time to list all his achievements. Without further ado, let's welcome Dr. Loro S. Bose to grace the stage.
Good morning. Thank you, madam, for the very introduction. Mr. Madhukar, who is the Joint Secretary for Health, in charge of digital health, members of the Institute, members on the dais, and also off the dais. And we also want to acknowledge the presence of all of our leaders from Northeast, from various states. You have come here with a specific purpose, and today we hope that as we interact, as we continue on with this, do this session, it will be beneficial for us so that it will take us with new vision, with new thoughts, and with new action plans. Northeast, in recent times, because of Manipur, has been made famous infamous in for various wrong reasons. But with the present day issues of violence and the wrong things that are happening in Manipur, the health infrastructure, for whatever lag it is, it has become more complicated, and it has sent people a lot of years behind time, and people are suffering. And I want you to think seriously into those things. Today, as we look at the physical infrastructure that are there in Northeast, the very fact that today we are thinking of the adoption of Industries 4.0, powered by digital health solutions, I think it is one area that is truly needful. Northeast India, for whatever it is, the geography, it is remote, it has been hilly terrain and difficult areas, communications are very poor. And because of all those various reasons, the fact that today we're discussing about digital health, I think it is something of paramount importance. Communication, as our sir has also mentioned, railway ends there at Dibrugarh, and in the southern side of Assam, it ends at Silchar. And then, of course, it goes on to connect with the rest of India through the Chicken Neck, Bongaigaon, and Jalpaiguri, and things like that. So communication as such within the Northeast is also very poor. Many of the states are not connected with railway. Many of the states are not connected even with air flights. Of late, a few airlines have started operating in a number of states, but it is not sufficient. We still do not have direct connectivity with many parts of the country. Roadways are also very limited. This district headquarters are connected with the state capital, but beyond that, to venture out into more rural areas, more interior areas are an issue. To travel just 100 kilometers, many times it takes more than 5-6 hours to travel. And I think in a world like today, in this modern India, it is unimaginable. It is also a problem in many of our rural India too, but because the terrain is more flat and it is more possible for us to drive around, it becomes easier. But in Northeast India, because of the hilly terrain, it has become so difficult. So we are talking about the sustainable development goals in Northeast India. There are gaps. These gaps are particularly when we are talking about healthcare, limited access to healthcare. Northeast faces the challenges in accessing healthcare services due to its remote and difficult terrain. Shortage of healthcare facilities, professionals. Northeast region has a lot of healthcare professionals that are lacking, be it specialist doctors or even nurses. Just the other day, between Christmas and New Year, that is just about 10 days, within that period of 10 days, I had faced, even in my own home, in my own family, problems pertaining to this healthcare professionals and also the remoteness of the area. My mother-in-law, who is now 94, she suffered from some issues of health and then she really needed geriatric care. The doctors who are there in the district hospital or maybe even in the primary health centers are not equipped with knowledge to deal with geriatric patients or geriatric care. Let us forget about the nurses. So sometimes I used to think whether in India itself we have geriatric nursing training as well. When we look at the West, the nurses are specialized in many aspects, many ways. But in our own areas, in areas particularly when we are talking about aging India, the population is aging now. And very soon, maybe many of us who are here within about 15 to 20 years, we will also be reaching that age whereby we will require geriatric care. And I am sorry to say that, I will not say I'm sorry, but I'm happy to say that our planners are also here in the health ministry. I'm sure they'll take up this issue with the geriatric nursing. I think it is one area which is very needful. One other patient that happened during this 10-day period is one of my relative who is settled in one of the cities in the Northeast, had difficulties in breathing. So that breathing difficulty, so they just put in oxygen, taken to the ICU, and between ICU and home with constant oxygen supply, he was going up and down. But his breathing difficulty never subsided. So ultimately, they transferred him to Guwahati. And in Guwahati, they found out that it was nothing to do with the lungs. He did have some little bit of fluid, but that fluid should not cause that much of breathing difficulty. But what actually they found out was he had problems with his heart, and which was not diagnosed in that city. in one of our own states. So unfortunately, whether it is because of lack of specialization or lack of knowledge, I really do not know. But when the patient goes from home to hospital to home and keep up and down and has been going through this problem for quite a long time and unable to diagnose the real issue, I think it is a problem. And therefore, today, when we're talking about digitization, I think the fact that artificial intelligence is also coming to being. I think this type of deployment of technology is so needful, and how artificial intelligence, it has got its own drawbacks as well. But forgetting about the drawbacks, it can definitely pinpoint certain diagnostic issues, and then treatment guides can also be given. And so I think these are also needful for us to be able to deploy uh, technology in our healthcare, and also the inadequate healthcare infrastructures. Of course, we have one of our from the School of Planning and Architecture, Suga is here with us, and I'm glad that they are also involved in trying to set up or try to build infrastructures which are friendly to all sorts of patients, including those deviants or physical people with physical disabilities. I think these are some important aspects that we really need to have. Northeast India has got greater lack of all of these infrastructures. The gap is huge, and we need planners to be able to involve in this more and more. And because of this very reason, when we started working at the Northeast MP Forum, we decided in the parliament during the last 17 Lok Sabha, we have 54 medical doctors. And I think that become the highest professional that is being represented in the parliament. Earlier, it used to be the lawyers, but this time around, it was the medical doctors. Now, when we came together as a Northeast MP Forum, we realized the need of uh, reaching out to the last mile, need of reaching out to those underprivileged, to those that are settled in remote areas. They can be reached only through the deployment of technology. Technology, by that, we will be able to connect with the last mile, and which is why the 5G technology was also introduced. 5G is an application which on our Android phone, we can take ECG connected with the cable to the patient. ECG can be taken. And then the report is being sent to the cloud, through the cloud, within 10 to 15 minutes, the reports will come. And whoever is attending, the doctor or the nurse, or this can be even taken up by the Anganwadi workers. So when this report is seen and that there is a seriousness detected, a serious problem detected, then proper reference could be made to the best doctor available. And so otherwise, many times, anxious as we are, whatever little problems that we have, the patients become so anxiety feels them. Because of those, they keep on going up and down and then spend more than they should. And so when proper diagnosis is being done and proper guidance can be given, I think it will save the patient from overspending, save time, and it will help us to be able to deliver better. Now, why I'm saying all of these things is because it is particularly in Northeast. I think all of us are from Northeast. And of course, those of you who are not from Northeast also are concerned with the Northeast issue. And also, you also have similar issues in your own areas as well. Now, when I'm talking about Northeast, because of remoteness, because of terrain, it becomes so difficult. And so we really need involvement of deployment of technologies in our areas. And so digitization of healthcare, I think it is of paramount importance. the digital health solutions that we are thinking of, is, it has been mentioned, of telemedicine, artificial intelligence, Internet of Things, blockchain-based electronic health records. Health records, I've seen that it is best maintained only in CGHS. Besides CGHS, we have got various institutions like maybe a medical college or institutions like that. They may be maintaining. But outside of that, in the rural areas, in rural health facilities, we have nothing of those. Particularly, we suffer because of lack of connectivity also. We do not have internet, we do not have telecommunication through which we can link up with the rest of the country, or even for that matter with the state district hospital or the district health administration. And so I think these are some things that we really need to look into. The gaps need to be filled. The digital benefits of digital health solutions will give us improved access to healthcare. It will enhance healthcare quality, including reduction of errors and improving patient outcomes. The increased efficiency will be there, better health outcomes. So we really need what we are going to be discussing the next 2 days. Proper implementation roadmap needs to also be evolved through this. I think the ministry already have a number of roadmaps already laid out, but whether they are actually reaching rural areas, whether they are actually reaching our patients, whether they are actually reaching the healthcare deliverers in the rural areas, I think these are something that is important. I used to be a general practitioner, practicing as a general practitioner in rural India. And not to speak of, these technologies or internet or things like that, even medicines are also not available. E-Sanjeevani has come now of late, but still we suffered lack of the adequate services provided in rural India. And so I think these are some things that we really need to actually look. I'm grateful that as a member of parliament, we were able to initiate a few things, not only on health, but also on various other digitization of, we're talking about oil and gas corporations, and also in the tea estates, and also in various other corporates where there is need of deployment of technologies, particularly the 5G. And I think these are being taken up. But the most important today that we are talking about is because of growing aging population is there, because of the rural health, the remoteness of our areas, because of difficult terrains, the deployment of these technologies, digital health will be most beneficial. And so I want to encourage our people that as you deliberate on these issues, please also think of how best we can, take this into our own areas so that it will help aid our practices, and that the health planners will continue to think of areas which are needful, particularly geriatric nursing, and also maybe in hospitals we also have a lot of other issues which are also needful. Pediatric nurses are also important, but those may be settled mostly in hospitals. But geriatric nurses, I think, if they are, as I was talking about my own grandmother, my mother-in-law, 94, and she was suffering so much. There was nowhere from where we can get any assistance, except that the children of the mother had to come and personally look at things. But it becomes difficult because they are also not technically trained. And so bed sores will come, and then difficulty in bowel movement, difficulty in feeding, difficulty in understanding, the hearing becomes weak, the vision becomes weak, and how best to attend to those type of elderly needs. I think these are some areas where a geriatric nurse can also do. So I think I want to thank you for giving us this opportunity. Make the best use of these 2 days, and may we go back empowered, enlightened, and that we will be able to give better services to our people. Thank you very much and have a wonderful day.
Thank you so much, sir, for your inspiring words and valuable insights. Your passion and commitment to the welfare of Northeast is truly motivating and remind us of the importance of our mission. Now, I want to invite Dr. D.K. Yadav, Nodal Officer, NIH FW Amtron Collaboration, to give an overview of the workshop and a note of thanks.
Thank you, Amna, and very good morning, the distinguished guests on the dais, experts from the academia and industry and research institutions. Welcome to NIHFW and in this particularly workshop. So, as our Honorable Prime Minister already said that we are considering these eight northeastern states as a 8 forms of Madhuta. With this vision, he has started a very, ambitious project that is called PM Divine. So Mtron is very doing wonderful job under this PM Divine project, and since NIHFW is a TAPEX Technical Institute under the Health Ministry, and our mandate is to promote the public health system and strengthening of health system in India. So Northeast is a good opportunity for ourselves also. So we are thankful to Mtron and especially Dr. Doro for this collaboration. So in this particular workshop, our secretary ma'am and they are also emphasizing on that we have a continued medical education because when the letter from Dr. Loro has came, so he already emphasized on the continued medical education in Northeastern states. So in health ministry we have a Saksham platform and we have a network of medical colleges that is called National Medical College Network. That is around 100 medical colleges network who are preparing the online content for the Saksham portal for the medical students as well as faculties. So this is a good opportunity for all of us to brainstorming that which particular courses can be taken from the northeastern institutions like AIMS or NIMS, like they have a RIMS, Imphal, and great institutions are there. So in this particular workshop, we have different sessions as per the emerging areas of the health where this technology can be done, imparted. So we have sessions on mental health. We have a session on continued medical education and infrastructure, data analytics, assistive technology, disability. So, and we have lab diagnosis, remote screening in the community, geriatric care. So, we have a good experts in this workshop. So, I hope you will enjoy this journey of learning in these 2 days. So, thank you once again for joining this consultation, and thank you all.
Thank you so much, sir. Your explanation highlights the critical role this collaboration will play in transforming the healthcare through technology. So now, we will now take a short break. Before that, we kindly request everyone to join us for a group photograph to capture these memorable moments. Once the photograph session concludes, you may proceed to enjoy your tea break. Please make sure to return by 10:30 a.m. as we resume with the next session. Thank you. Whenever you are free, sorry.
opportunity given to DIC, which is Design Innovation Center. So at Punjab University, we have a center that works on innovation, digital technologies, 3D printing, and many such aspects through which we are supporting Amtron and the Northeast region in across various projects for 5G, 3D printing. So few of the projects that we have been doing with the Northeast region is firstly 5G applications, wherein we have, as we have discussed, on screening devices for medical applications and everything. Then we have also worked on under the PM Divine scheme for the 3D printing center of excellence, across which 10 locations have been established, wherein 3D printers, 3D scanners, and all these infrastructures has been built. And the recent is the deepening of 5G use cases, with which we are working with the NER region with NERCOMs. So what we have faced across all these projects is because of the terrain, geography, demographics, such a diverse region is the northeast section that people have to spend a lot in transportation, which is a major challenge. So if any person has to avail any treatment, firstly he has to leave his workplace for that particular day. That means if he's a daily wager, then that day's wage is lost. Along with him, there is another member who will support him while traveling to the other place, and this much he has to spend only maybe for diagnosis only, which is easily avoidable if we have a stable 5G screening setup or a screening ecosystem. Further, as we see, there are other aspects also like oil and gas. Again, it is a sector which is very progressive, but it needs high-end 5G technologies. Telemedicine, as we had already discussed, and also we have talked about lack of specialist doctors. So if we have limited number of healthcare specialists, it's important that we engage them where they're really required. If through 5G devices we can automatically through AI detect the problems, then that specialist will not be engaged until it is a serious concern. So what we suggest is that to develop an ecosystem using 3D technologies, artificial intelligence, 5G network, and maybe even we further go towards augmented and virtual reality to remotely treat as much as possible, as much as diagnosis, so that there is lesser pressure for physical engagement of the patients and the physicians. Then there is as such no critical study on occupational health challenges which many people face while doing a lot of jobs that are specifically to northeast, for example in tea estates, in oil and gas industry, many lower level jobs. So ultimately, as I have discussed, that we need a digital infrastructure setup for which funding support, manpower support, capacity building workshops as the need of the day. I think that's all from my side.
Thank you everybody for coming. So first of all, let me introduce everybody. Reena madam, you coming for the first time in the Northeast event. It is a long journey that we have covered in the last 3 years. You know, when I started this project pre-COVID, the bureaucracy had a lot of resistance to digital infrastructure that time. But COVID changed the mindset. COVID was a big game changer where people started realizing, and for me, the biggest challenge was to bring the pulse together, whom to contact, things like that. And slowly we started a journey. Dr. Loro Fose, whom we met, introduced me to a lot of member of parliaments, doctors. We went, knocked door to door. And then, you know, special thanks to Puranik sir from AIMS Guwahati. I call him a rock star because every time I go and meet him, he says, "Ki karo. Don't worry for processes, do it." Sunil sir, he joined and we wanted to do a lot of project in terms of file. Unfortunately, because of one order, we could not do. I have my colleagues from different 5G labs and 3D labs that we have set up. It is very easy to do in plain areas, but in that part of the country, getting together people was, but we covered that roadblock. And we are very proud, some of the things that you see here, It is not even implemented on that scale in mainland India. Can you go to the next slide, please? Before we start the process, madam, though in India we go ministry-wise, but in Northeast, these are the three very important agencies. NEC, prior to, don't know was formed only when Vajpayee government formed. Prior to that, we had NEC, it's a constitutional body which has members of all the 8 chief ministers, chief secretaries, governors, and headed by Honorable Home Minister. He is the chairman. So as a regional planning body, they decide what to do. So most of the money that we got initially came from this body. Obviously now there's a donor ministry. And another very important aspect we should know here, all of us health planners, that Government of India, Honorable Kalam Sahab passed away in Shillong. I am Shillong. In his memory, we have got a Center for Policy Research. APJ Abdul Kalam. Now it is mandated by Government of India to be the regional planning body for everything. So whatever initiatives we want to deploy, we must take them into loop also because they'll audit all your schemes related to it. So we must dovetail our initiatives with them. And they're the central research pool of all kind of activities. Next slide. And this is how it started. We were celebrating 50th year of next one more. We were celebrating 50th year of last slide of golden jubilee celebrations of NEC, and Honorable Prime Minister had come, and he said that I don't want anything in physical infrastructure. It is going good. What about digital infrastructure? We have to break the barrier of development because your remoteness, how you can use technology. I will not bind you by any particular scheme. You bring a scheme, you tell what money you want, and we'll give you the money. And that is how the PM Divine came into force. So I was working on the scheme from day one. Next slide. And this was a mandate that Honorable PM said in his speech in NAC addressing all the chief ministers. Please use technology to address these gaps. Better healthcare, gender parity, education, innovation, inequality. Inequality is a very important subject because if you see the resource utilization in Northeast, probably 80% will go into Assam, 3-4 odd percent Tripura, 3 or 4 odd percent is Sikkim. This is only 1%. And most of the time, it is a planning department which fails to put together the needs in a proper document and it to this don't lots of money because we are unable to plan properly. We don't seek the money, the scheme is not implemented. In fact, there are a lot of schemes of money is available that utilization does not take place. And it's very important that all of us know where the money is, which are the schemes, and utilize it for improvement of healthcare infrastructure. Next slide. We had a meeting in PMO also, thanks to Loro ji, we had a meeting, and there also same thing, PK Mitra sir said, use technology. Don't go by normal conventional means, use it, break the barriers, be disruptive. Next slide. So, we all of us are talking about industry 4.0, these are the technologies. But what is more worrying is the slide after this. When it comes, we are talking only about some outputs. How it's going to affect my manpower? Because North is still reeling under unrest and a lot of young people have laid down arms. If we don't skill them with the right sets to come into economic mainstream, they'll again pick up arms. People pick up arms because you don't have any education, lack of roads, lack of water supply, lack of healthcare. I have worked in Bodoland, I have worked in Bokokchong, Changlang. These are some of the disturbed areas. We started connecting with people. And once you connect with them, the real problem comes in the picture. So it's very important that we equip young people of today to address the challenges of society. If society gets alienated, because that today it is without Northeast, we have a lot of economic interest in Burma, we have a lot of interest in deep sea port in Chittagong. That's going to be a main resource center for a lot of critical minerals for expansion in Asia against China. We need to keep this region intact and development has to take place. So we need to inculcate, so technology should be inclusive, not exclusive. Currently, technology is excluding people. We need to educate them, train them, bring them into fold, make them useful for people. Next slide. And my mandate, which I am also implementing phase by phase, is that's what CEO needs. In fact, he was a Manipur cadre officer. A lot of people don't know about it. When he joined as SDM, there was no bathroom. So he got his cadre changed from Manipur to Madhya Pradesh. But he did serve as SDM in Tamenglong for a long period. So when I met him, he said, Anand, break the middle income barrier. Using technology will provide you with funds, but please ensure that jobs which are created everybody is getting at least $18,000 per annum. Then India will become a developed country. Only becoming Delhi, Bombay, Chennai, Pune will not help. There is large India if we don't make it progressive through any means, create jobs. Next. Next slide. So the scheme, madam, is called Northeast Revolution. It is basically being steered by Niti Aayog. Everybody is a part of it. And using technology to bring revolution Northeast and addressing those SDGs. That's the whole scheme all about. We are very thankful today. Rajaraman sir is not here now. He's been transferred. He was earlier telecom secretary. He was very supportive initially. All that we see today, Dr. Loro, K. Moses Shalai, currently Secretary, Interstate Council Secretary, Rajaraman sir, these are three people were go-to people. In fact, against finance, he said he didn't listen to finance. He said, you go. I know the need of the region. And that's why we have this scheme. It's a very successful scheme today. We have a lot of success stories. Next slide. And this is the change, madam, which came. Now, change is now institutional. We have interministerial committee, which we have members from all departments. They are called over there. There's a special budget for that. And we are the only PSU who were coopted into this interministerial committee. Everything is documented and targets are set. So from thinking perspective, now there's a proper policy document with clear output documents. We have to use Industry 4.0 to address the SDGs plus create economy of $3 billion in Northeast. That's a target given by government, no matter what. Next. And this entire journey, in fact, in health also, more than NHM, we must engage with all the lawmakers. I will request, please give me whatever is on in Sanjeevani, your all kind of public commentary, wherever is the e-health programs. The first thing which we need to do and educate with the help of Speaker of the Vidhan Sabha, with Northeast MPs Forum, what is the scheme that we are talking about? Because when you go, people like me and you will face barriers in language, society acceptance. These people know the local leaders. When I went to Arunachal, I realized that part which I'm working as about Adi tribe, I went to the leader of the tribe. Immediately in 2 days, he brought me 16 load full of buses of people to come and get screened. This is a disconnect. We must speak to lawmakers, and I'm very thankful to our former WCT minister. When I went to Asmiti Rani madam, she said, Anand, what are you doing? And we hosted a special radio program, Nayi Soch, Nayi Kahani, on Northeast. She ran a program on AIR for a long time. We kept on talking about new initiatives. So we must, as policy bureaucrats and policy makers, doctors, we must engage with them because they have the pulse of people. They'll tell you how to deploy it on the ground. Next slide. And we also engage with a lot of youngsters. A lot of people whom I find who drink, if you go in to get the kids, they'll ensure that the parents don't drink. Arunachal, with such a small population, is one of the largest consumers of alcohol in the country. Imagine. Population is just about 12-15 lakh. Imagine the health impact. Next. And a lot of our ideas that we are implementing, madam, it did not come from us. When we started speaking to students, self-help groups, women in the society, local leaders, they gave us the problem statement. And hackathons give us idea where do we put our efforts together. And where we require help of NIHFW is to organize more hackathons in the healthcare domain. There is a problem, come crack it, take this money. And then, we have oil companies, we have a lot of other agencies, REC, who in fact, fortunately now we have good sprinkling of officers from Northeast in major departments. Civil aviation, Rural Federation Corporation, every on power, all is cash rich. We can take the CSR budget, there is 10% budget for Northeast. It's hardly utilized. We can use that money to run a lot of your programs, awareness, deployment of ground, lack of machinery, we can put more machinery. Next. So first thing which we realized, madam, today, before e-health, you require that highway, we will take that e-health to people. And that's a digital connectivity. The problem in Northeast is we don't have enough trained technicians to lay optic fiber on the ground. Even when optic fibers, 90%, the data shows even yesterday, Nithya, we had a meeting, that it's not lit up. Data is not being used because there's no way to maintain and repair the telecom equipments. And you have a problem of languages. So we have set up 8 5G labs. There we train telecom engineers how to deploy infrastructure. And I'm seeking a budget. In fact, we shared that note with you, madam. It has got a telecom ministry, a DOT minutes of the meeting. We have a budget called USOF, Universal Services Obligation Fund. It's a 80,000 crore budget unutilized in the Ministry of Finance. The purpose is to use this budget to ensure connectivity in the remotest part of India. It is not for profit initiative. There is no ROI. Even if a village has 5 people, and if I need 5 crores to put up infrastructure, we can use that money. Please use that money, make a map of Northeast. I can help you in the process. We map all our PSCs, CSCs, sub-centers. We can connect each and every using this budget. Entire money can be pulled from there in with one stroke of pen. Maximum Northeast million is 3,000 crores, nothing. It's just not even 5% of the budget. Every year, the budget is, the pool is increasing, but money is not being utilized. Next. The second is, madam, in Northeast, we felt that no matter what you do, optic fiber has limitations. One landslide, Sikkim is an example, one landslide, half of Sikkim will go dark always. Always. What happened in Tista, dam break? Entire state was cut off from communication for a long time. So we are going in for LEO-MEO connectivity. Next slide, please. So we have developed a solution which we are now pilot testing in Bombdila and Arunachal. If that goes well, it will be the first deployment of where we use satellites to provide high-speed 5G network in remote areas. Again, this is centrally funded. But no state government money is required. 100% budget is from central government. I will suggest that if there is any PSC, CSC where we cannot go wired, this is the medium. We can provide with resource people. We can do it in a, let's say, 18 months, 20 months time frame. We can identify and connect all the remotest areas. There is an issue, madam. When you're not connecting the remote areas with healthcare services, people migrate. That's a security risk. Anjaw travel in Arunachal Pradesh. This other side is China. Same tribe living on both sides. That side they see houses, hospitals, mobile connectivity. This side the DC uses Chinese network to call Indian counterparts. Even today I'm talking about. It is a discontent in people. I'm living in this part, I'm not getting this. When people migrate from border areas, it's a major security risk for the country. And that's why Honorable PM is stressing again and again, develop the border areas. It is the opportunity. So we must use satellite network to connect wherever required for all the healthcare infrastructure. Whether wired or wireless, money is not a concern. I tell you that meets the meeting, I can help you draft documents. Please pull that money, get it deployed. Next slide. The other thing is medical imaging is changing. Treatment is changing, madam. E-health. We are having a lot of things, but where is our money going? Please sit with the Ministry of Commerce, the amount of money we are wasting in design royalties. Johnson & Johnson and Stryker are the two companies providing implants in the country. When they repatriate their profits out of India, so you have to tell the Ministry of Commerce what is your material cost, what's your royalty cost. It's almost 70% royalty on design royalties. Same thing happens in oil and gas. Because what PM said on 15th August last year, design in India. If we don't have good designs, whether it's a medical implant, devices, patents are not here, we'll end up importing all expensive things. So we have started, you must visit this, madam, we have started a school with Dassault. Dassault is the Rafale maker aircraft. Anything which is designed the world expensive is all on Dassault platform. Most of the medical equipment hospitals are designed across Europe on Dassault platform. So we started giving training about design, industrial design to students. And we'll show you what all we are designing over there, how it's bringing employment to people. Healthcare also one of the beneficiaries. Next. Second thing is that Northeast was always looked down upon. When I started this, somebody laughed in Niti Aayog that nothing will happen. Please come and see in 3 years what we have done. We are very proud that last year in India Mobile Congress, we bagged the best display award in the country amongst everybody. And not only that, we have been given money this year, Ministry of External Affairs, to hold workshops on these two initiatives, 3D and 5G, across the world. 70 countries we have to cover this year. We will take NIHFW as a partner in that. Healthcare demonstration of what we did in Northeast, because large parts of the world also healthcare is not affordable and accessible. We developed some very low-cost DPIs, and that journey is not alone. Everybody sitting in this room helped. Next. I also work in United Nations. One area where we are deploying e-health map. I had a heated discussion in United Nations. I went in Vienna. How is West ripping us apart? Luxembourg, which has a population of 5 lakh people, has developed a health standard which has become universal across. On 50,000 people they have tested. It's a global standard for Europeans. They call it the clean data lake for healthcare. We, on the other hand, if I sneeze in Delhi, one ward will have 5 lakh people. We have the population, but they control the standard. This cannot happen anymore. As a country, if people are there, everybody, we must, we are very fascinated with white skin. But let me tell you, madam, they are ripping us apart in design patents and royalties because they control the standards. We have to work, hospitals have to work with engineers, with industrialists, everybody, MSME, to develop local products and services so that we control the world, not vice versa. Because imports are rising every day. Every day it is rising. It's a huge cost. We are also working very closely on developing export zones in Northeast. 2 of them you'll see very shortly with the help of MEA. Next. This is an interesting subject that I picked up. We are setting up India's biggest MRO in Northeast. It's with Rafale. I dreamt it and it's going to happen. But one of the biggest offshoot is healthcare. When I started designing what are the outputs of this MRO center, healthcare of pilots. They are saying they want wearables which can monitor because pilots require certification. They are drunk, they pay money, they take service, they fly the aircraft. You can't allow a drunk pilot to operate. So they want, if you can develop a wearable, Air Force wants it. The head of engineering of Air Force came to us in Guwahati because we are neighbors. Said, why don't you develop a wearable where I can monitor each of my people who's going to fly the aircraft? We are having 18 forward bases. This is a huge industry. And when this comes, this is one industry will bring in at least $1 billion to Northeast. We are buying 1,000 aircrafts, repair and maintenance, all spare parts, major repairs, aircraft goes to Singapore. In India, we only do the lowest end of repair and maintenance. Next. With oil and gas, again, we are setting up India's largest GCC, Global Competency Center, because currently everything is imported and healthcare, occupational healthcare of oil and gas is totally unaddressed. We were able to, thankfully, Gangotri of oil and gas energy is Tinsukia, Big Boy, where oil was first discovered, and we set up the GCC, where in 3 years you will see that the largest, outside of Bangalore, is the largest knowledge center on oil and gas, with healthcare of oil and gas employees also a critical component of that. Next. Next. So I'll not speak much on this, but madam, I'll give to this book, and all of you sitting here, you must read this book, The Great Escape. You can have a huge defense force, you can have, but if your health is not good, the economy will sink. It's a lesson which is, this book was written after plague in Europe. Your whole economy will wipe out if your health of your population is not good. So you must invest in healthcare infrastructure. If that is not good, nothing will succeed. First and foremost, no kid will go to school. No worker will go in the factory. Next. This, madam, our first use case, which I want, in fact, I said JS Health also, you also, and all of them. Healthcare access. I went to Tripura, Agratala, and the hills all around. The tribal people come in the hospital. There are limited doctors. In Arunachal, you will not have a single dental lab to support dentists. Industry sector of Arunachal spent 2.5 lakh rupees in just getting one implant done. 1 lakh for the doctor and 1.5 lakh transportation from Itanagar to Guwahati. Sarchip is the hometown of Honorable Chief Minister of Madam is from there, of CM of Mizoram. The DC travels 16 times to Aizawl to get a cap done. This is 2024. We have set up one lab in each state of Northeast. The entire process is digitized. People come in the morning. So the impression taking, painful process, open the mouth for half an hour, 45 minutes. You have to call the technician. He is not available. Every part is made by human hand. Perfection is not there. So I require multiple milling, chiseling. It's a painful process to get a simple treatment done. Can you play the video, please? And that video also. So with this half an hour, 40 minutes of opening the mouth to get impression done, our impression taking is completed in 5 minutes flat. If for a full-grown adult, once I capture the morphology of the teeth, for second, third treatment, any other treatment doesn't need to come twice. It's already, we can link it to ABBA card also at a later date. Then AI does the designing of the necessary orthotic part in the mouth. prosthetic part or orthotic part involved, whether the crown or bridge or denture. AI does it. Doctor doesn't do anything. No lab is required to do anything. Then we print and give it. If you go to Government Dental College, people come in the morning, get treated with a cap and a RPT, and go in the evening back to the homes. This is the change which is on the ground. We are not talking about in air. But here, we require help of an IHFW to train more technicians. And here, madam, we are starting initiative, and we'll love you to, because it's a women-centric enterprise. How will it create jobs? So we were going to train, just like Yakult service, we're going to train women from Northeast, tribal women, give them a scooty, a laptop and a scanner. For a fee, they'll come and scan at your home. And we'll show, I have done with IM and Shillong, a lot of survey. A lot of people are ready to pay 2,000 rupees for a home-based cancer, because a taxi in Mizoram will cost you 18,000 rupees per day. Arunachal, no limit. Only in Guwahati you'll find in what 4,500 rupees. Other than that, it is whatever the driver says. For them, it's much easier. They call up a call center. A girl will go to your home. She is trained, certified. She'll scan. We'll have the data. The dental doctor, the surgeon will examine the data, and we'll make the part only come only once for consultation. We finalize the part, print, and go fit. Multiple is gone. This is going to create new enterprises. And Bangladesh spends, that is, I had the opportunity to work with Harsh India, sir, former foreign secretary, was earlier India's ambassador to Bangladesh. When sir was there, we had calculated that Bangladesh is spending about $3 billion in treatment in India. But that's going to Calcutta and Chennai. While we have such a huge border with Bangladesh, why should somebody from Chittagong go all the way to Calcutta? We can fly people nearby, give them treatment, even at the border checkpost, Transport Authority of India. For example, in Tripura, in Agratala, Akura, is the border checkpost, right in city. In fact, when you land up in Agratala, the signal is of Grameen Bangladesh telecom signal. We have started working with a law enforcement authority of India that each of the center will train our own doctors, technicians, open up private commercial clinics, enterprises, and the first center is opening up in Blating in Arunachal. That's funded by MEA. Next. Prosthetic treatment, madam. Unease of living. A man or a woman or a child without leg, if in 2024 has to travel multiple times to a hospital just to get a design finalized for a prosthetic leg, 6 months time, getting UDID card is a painful process. Very painful process. In Delhi, madam, you will not get before 6 months. In smaller cities, for a disability certificate is not accepted by Government of India. They want UDID card. Then, if it is raining, the cast will not dry. Come back again. Even if cast is taken while transport, if it's not fully dry, the design will change. It will be not fitting properly. Next slide, please. Next. This is, madam, how technology and AI is shaping treatment of disability in Northeast. What a hospital can or technician can do in 6 months' time. We scan the amputated leg, we design the leg virtually in 2 hours' time, and a patient can give a 3D printed foot on the 3rd day. Next slide. Next, please. Can you play the videos? This was my first patient in Meghalaya. We talk about a lot of achievement in advancement healthcare. There are 1,500 people without leg in amputated cases in Meghalaya. Can you play this video? Every year, Meghalaya government provides leg to only 5 people. It means it will take 30 years to provide leg to people. Half of them will die. And madam, there's a sad side of amputation. Brothers are throwing out brothers and sisters from family because they don't want them to have a property share of a disabled person in their own family. Next. Next slide, please. Another girl. Her father had heart garlic after drinking. We picked up this girl on the streets, police bazaar. And this was a 3D printed foot. She's now going to school. That's the success. That's Antodaya of technology going on the ground. We should respect humanity. Rich or poor, leg or no leg. We have to be human towards people who don't have it. We're very privileged. That is where technology is going to hit very hard on the ground. This Honorable Prime Minister's vision of Antodaya is something which e-health can take on the ground. And I will give you success stories where pain can be solved, and they give you so much of blessings. My energy comes from this kind of people. Next slide, please. I want you to go and meet this girl. For last 3 years, she's going to school. Next slide. Next slide, please. Another case, madam. All kids are whole day looking at mobile phones. The next healthcare challenge coming is basically dislocation of backbone. In a private hospital moment, there is a pain, they'll open up the nerve and kill the patient lifelong, immobile. But scoliosis, we have 10 lakh listed people in this country. It's going to be a major health challenge. We can give braces. The current treatment, this is Delhi, this is not Northeast. This patient was first came to Sarjang, then was referred to IPH at ITU. This girl went into depression because of this. There was a lot of bruise on the body, unable, very difficult. We said, we don't want money. Give me a chance to treat this patient. A lot of resistance from the doctors and the planners in the Ministry of Disability. I said, I'm going to underwrite. Something happens, then jail me. This was the patient, madam, we designed. We gave her a brace. Can we go to next slide? Can we play the videos, please? Honorable President came to see this child. This child is totally cured now. A case of scoliosis without surgery. She is now totally recovered. And this case study is going in WHO for presentation by Government of India now. Honorable President came, she saw the child. She was a cancer survivor with scoliosis, now fully treated. She is also a model now. I'll bring her to you. You meet her and see how technology has shaped the life. And this is what we need, can take easily to people. We can scan people at home. Why need to come? And I don't want to make my doctors, clerks doing paperwork. They are high skill set people. We should use them to provide treatment, not to do mundane paperwork. That's the job of AI, to do the mundane. The clerical job should be done by AI. Doctor will treat. So doctor told us what's the degree of support that the backbone wants. We did that on software. Can you go to the previous slide, please? Previous. That. You see that, madam, we do virtual fitment. When you do manually prosthetic, the fitment is never proper. Here we virtually, every micro nanometer, a millimeter accuracy, we ensure that is supporting the backbone. This a manual system can never support you. And madam, another aspect, prosthetic is a $50 billion industry. India's share of production is 0. So much so. If we develop this with our own healthcare providers, I am talking to MEA, give me empty village of Northeast and Uttarakhand. We'll bring in patients from outside, treat people, because the treatment costs in Germany have traveled to all European countries is 1 crore plus. Even I put a flight ticket, we'll develop homestays, 1,000 homestays, bring people from the world, treat and send back. 2 things we can do is very easy, 3 things. Geriatrics, prosthetic care and dental care. Very expensive in the West. Even after flight, and instead of a nurse and a technician going and earning 2 lakh rupees, 1 lakh rupees there, see the cascading effect on the economy. If we develop these kind of villages, health villages in the hill in India, homestays, food, PR, financial services, transport services, whole economy will develop. And world is aging. You have manpower, but why should I sell my manpower for cheap? Next. Unlimited application, madam, arthritis. And these are all customized. You can never manufacture mass manufacture. Every patient is different. Stroke cases, splints. Next. Cranial helmets. For kids, softening of heads, bulging on one side, flat on the other side. You can't mass manufacture. And these products can be made by small enterprises run by women. You don't require rocket science. One cloud can support everything. The database that we generate, madam, will support your suction platform, teaching. My friends, when I was growing up, my friends who became doctors later on, they used to go and get expensive photostat from Naisarat. How many books that we are teaching our kids have got Indian use cases in the books? So only Wiley books, even today. If you go to National Medical Library out here next to AIMS, you can only find foreign publications. This suction platform is so important for us. The database that we create, madam, will be used to teach Indian use cases to our frontline healthcare workers, for researchers, for doctors. Because knowledge which is created in the OPDs and the surgeries, that's still in silos. Next. All kind of disability treatment. Next. This is a use case thanks to Dr. Puranik. You gave us a chance. You took the risk on us. Can you play the video, please? This is a case, madam, where there was a bone cancer. This is a portion out here. We were given this CT of the patient in Guwahati. Thanks to AIMS Guwahati. Dr. Malia, are you there? Thanks to you, great. Please give a clap for him. He is a treating surgeon from AIMS Guwahati. Dr. Puranik gave us a chance and Malyaji helped us with his team, and we were able to distally design the implant, give the implant to the patient at a fraction of cost of Johnson & Johnson. We'll bring the cost of treatment. You have done one good initiative, which is your low cost medication. Same initiative we can do for implants also. They're ripping us apart in expensive implants. And madam, you know, as in Northeast, because Tambul, Gutka, oral cancer, for maxillofacial surgery will be required in oral cases. So that to have a normal face require implants. Again, where you get it? I'm saying we designed in the same hospital, we printed, give it, and that's already the facility is paid by Government of India. In Guwahati, you must come and see it. We have the largest 3D printing facility supporting this in Guwahati. All the machines are there locally. Next slide. In brachytherapy, true health. When you give radiation, those pipes, if they don't go on the right spot, radiation spreads. So your dose is not as per plan. And currently you make them open the mouth, plaster Paris against and cast method, find the lesions. Painful process. We can reduce the time of brachytherapy treatment by first scanning the mouth with intraoral scanner. Then we can print so that, you know, instead of the manual cast, it is the 3D printed cast. Treatment time is very important in oral cancer because more the relapse, the spread is very fast. And the maximum patient load of oral cancer is not this. Not only we can affect both the brachytherapy treatment process also and plus implants. Next. This is another health challenge, madam, which we found in Northeast. People having problem of walking. In fact, WHO data I'll share it with you. 1 in 3% of the world will have problem of walking because of lifestyle issues. And that ankle pain is not very simple. Probably somebody has ligament here, something like. But we produce what about 20-21 podiatrists in a year in the country. Such a mass population. It's not orthopedics, it's podiatry. It's a start of science of only studying the leg. I'll request you please start course on podiatry with NHFW. I'll get you all the content. Today again, this whole thing is controlled by a country called Belgium, which is this small. And they have mint money on podiatry. Next. So can you play the videos? We started this initiative, madam, of distal foot scanning. Without gait analysis, the scanners, and there is a mat, you walk on that, we scan the leg. It tells you the arch issues. We use the arch issues to first treat a problem of high arch, low arch, or flat foot. Every flat foot is very common. And we are going to support new enterprises where women will make 3D printed insoles and shoes. We've already done our pilot projects with the security forces, but I find that building other construction worker welfare board, big migrant laborers, one segment, tea estate, oil and gas. Surgeons who are standing whole day. Your ASHA workers going on the floor. If the foot is not good, where then the work? And in Manipur, when we did a survey with Loro sir, we had a 30% population which was having motor issues. In 130, that's an alarming figure. Next. Lack of cadavers. Medical teaching. A lot of medical colleges don't even have cadavers to, you know, for the doctors to practice. Virtualization. We have, thanks to PM Divine project, we have a full body cadaver printer in Guwahati. We can, you know, take the CT scan of a live patient, print a cadaver and give it for people for learning process. And the beauty of this is that it's got 3 lakh colors. It will create exact replica, skin for skin, bone for bone, cartilage for cartilage, veins for veins. And this is my example of virtualization of training. You please come with me to a nursing college in Pasighat, where kids, because nursing college not have enough books, teachers, they are learning all the anatomy classes using AR/VR classes. This is the future of learning. Even in, I will suggest, in fact, we have prepared a program with Dr. Puranik for funding under PM Divine, where we'll set up a lab within IHFW to create this kind of content using AR/VR technology for training. Next. This also doctors have to address forensic medicine. You have enacted the Venus Act. The law says precise data collection. Accident happens in 5 minutes. Everything, if it rains, every evidence will be washed off. The same scanners that we use, I'm now conducting training for National Forensic University, Gujarat and Tripura, where we're training forensic doctors that or examiners that how do you collect evidence on the spot. We can completely digitize the crime scene and no tampering is possible after that. What I cannot see, we can use technology. We need trained technicians for this. We don't have in the country. The law is there, but we still are taking photographs. That is not allowed under law. Next slide. Any kind of complicated surgery. Here, AI and Industry 4.0 will play a very, very important role. Where metastasis is there, madam, in a cancer case, or Puranics is there, Sunil is there sometimes. You get a CT data for a doctor. A CT is 2D. When you open up the patient, it's completely different than what you see in a CT. So what we are doing is that we have developed a small open source application. So madam, here's the problem. And Puranic sir, in fact, I mentioned that to you in my meeting in Guwahati. When cancer comes in the family, depression is the first gift. The second gift is multiple trips to multiple places for diagnostics. So you will not treat without a CT scan. So first doctor will write, get a CT done. Second trip to get a CT done. Third time to collect the CT data. Fourth, to get the CD examined by the doctor, because this is a pure Badmashi Gundagardi of Samsung G. They are proprietary softwares. So a CD, imaging taken in Samsung will only on the Samsung software, G in G. This cannot happen. We have broken the codes. We take up the data in the machine and do AI-based analysis of the volume of the cancer in 15 minutes. And that can go to any patient or his next dependent kin or whatever on mobile phone. They can share this data with the treating oncologist or the surgeon, even for tumor board, multiple doctors. So first, AI helps us to reduce the multiple trips. Secondly, we print the part outside the body. So doctor can have much better understanding of what is inside the neuro case or a GI surgery or a heart surgery. But with this, in fact, I will like you to run some practical tests. I think we can reduce the surgery time, reduce the usage of anesthesia and the blood loss. Because you know exactly what's inside the body before. We have the machines, we have the manpower. Any super specialty hospital of Northeast wants to, obviously I'll go and knock doors of Guwahati Medical College and AIMS over there, but even RAIMS, Nagaland, we must use this. And all this will go into e-learning platform of Saksham, training the next generation of doctors, engineers. Next. If there is scoliosis, I have to go for surgery. Again, we can plan the surgery. Next slide, please. Doctor needs to know what's the exact condition. And then we can design parts which can help posture correction. Can we go to next slide? Everything can be 3D printed. So first I use digital designing to tell the doctor what's the problem, doctor analyzes, and then surgery can verify, because I can make every body will be different. So we can, in titanium and cobalt chrome, I can print every part. Next. Same thing for bone cancer, any kind of cancer cases. That's where technology will play a very, very important role. And what I'm saying is that when we start developing this process, whether it's AI, things like that, you start developing standards. Saksham data will be very, very important to file IPRs and patents and creation of knowledge repository. That will create wealth. Why a country of 1.5 billion people should depend on West for standards? We must all ask. Amount of money that we're paying royalty, we should reverse the process. Next. Next. Any kind of pre-surgery planning. This is the best answer that you can have. This is what we have done in Madam in community health screening. When you talk about NCD, screening for hypertension, what will you do when distances are such that I can only cover 2 houses in the hills in a day? Pasighat, which is hospital since almost about 80 years now, has one technician. He doesn't come every time on time. Sometimes there's no power supply. Will cardiac attack or heart problem will tell you when it's coming? No. I am working very hard. We have done 8-state deployment with Government of India funding. I'm going to all the PSUs. Sanjeev sir, you can help us out. He's on the board of CSR of IOCL from Tripura Red Cross Society. we must give this kind of devices to every Asha and Anganwadi worker and let them charge some money to ECG. First of all, it's available anytime, anywhere. Secondly, this machine can give lateral long of the patient to 108 immediately. Lives can be saved within 1 hour. In Delhi also, do you have the chance to survive for 1 hour in the traffic jam? At least this can tell the heart condition of the patient immediately to the nearest hospital. Everything AI can do. Locating the nearest ambulance, intimating the doctor about the heart condition, even advice can be given. This is something we must integrate into the e-health portal, e-health scheme, and funding will come. In fact, tomorrow I have people from the tribal sub-plan coming. We are surrendering money, thousands of crores. We have just 10,000 panchayats in Northeast. Fund that, one device, nothing, hardly any cost. Next. DR, madam, will go with you in this, whatever you say. Currently using this. Next slide, please. So we are saying that job of ophthalmologist is to treat people. Anyways, we have very few ophthalmologists in Northeast. This device that we're using out here, it's a fraction of the cost of German machine. It will help you to screen on a scale of 1:4, and then you know that only the critical cases have to be referred to doctor for treatment. So whether it is integrating them into the Aadhaar records, your community screening, we can all work together to make it successful. The other area, madam, that we are working is with Ministry of Road Transport and Highways. The way medical certificate is being issued for commercial licensing is very, very alarming. And this data came to me from NRL, Maligarh Refinery, where Prabhulji was earlier there. In fact, we have the first deployment out there, where the MD told me that some drivers suddenly drive very slow in the evening. What's the problem? So DR is asymptomatic. So when we started screening, a lot of drivers were found to having DR, they're driving critical vehicles. You can't allow a refinery tanker to be driven by some DR. One accident and the cascading effect and the loss to refinery is very high, and their insurance goes up. So the Maligarh Refinery is the first refinery where 100% screening of drivers is taking place using this device. What we are talking to Minister of Road Transport and Highways, don't give us money. At every RTO, we'll get a person funded with 25% capital subsidy to put this equipment. Every driver should be screened. And that's everything gets into a e-health program automatically. It will be successful because insurance companies are very worried about accidents because of lack of proper vision. All highways, you're spending so much on national highways. Because it's just fraction of the cost. Hardly into the road safety fund. Fund is not a problem at all. We just draw that money, put it to the DR program. With this and refractometer, you can just scan population on the highways. And all the occupational services, whether it is ESIC workers, whether it's refinery workers, cane and bamboo, tea garden, everybody can cover that population. And Northeast, in fact, will have the mass from here only. Tea gardens, cane and bamboo workers, oil and gas. These are three principal employers of people that need screening. Next slide. There's something random, I don't know how much you it's called wash basin test. I'll give you some arithmetic in Delhi. Some of the biggest players in Delhi collect about 3 lakh samples a day. The Gurgaon facility has the capacity to only process 1.5 lakh samples. Where is the report coming from? What is the guarantee of your blood being transported in the right SOP to the testing lab? If you don't come without your MOH tag, I'll show you how they are dumped on the road in the sun. Now that is wrong diagnosis and wrong treatment. The second pain point came from BVCI, Bhubaneswar Barua Cancer Institute in Guwahati, that in emergency cases, the lab takes time to do a blood test report, and without that I can't take him to surgery or her to surgery. Can you develop a device? So under that PM Divine funding, we have developed this device, and now we've got CDSCO approval also of this product. 140 kind of tests in 50 minutes. What we are saying, this person is coming in OPD, wahin pe you put this device, get the report, and write the medicine, goes back. In emergency, you get the report immediately. In remote areas, instead of unlicensed, uncertified, unsanitized labs which are operating mushrooms across the country, this you can control by IoT, everything. In fact, I can get medical codes also from this on a larger database. I can run AI. What my major indicates, what my major problem. So these kind of devices are devices of future which will help the e-health program, because the data collection process is still not there in the country. You license the labs, you license the all the diagnostic centers, but we are not mandating them to submit data. We must dovetail our laws to ensure that they put the data in the health program. Next slide. Next. The first thing, madam, which I'll request you is that we are building a lot of hospitals. AIMS, I have been working with AIMS Guwahati. I think, sir, that the cost is about 700 crore rupees. AIMS Guwahati cost. Sorry? AIMS cost is 700 crore rupees, construction cost of AIMS. Yeah, they were estimating the size, this 718. Yeah. 700. We spent 700 crore rupees, but the hospital, a lot of functions don't happen because of lack of proper internet. What we require, sir, in the planning process, I have got Dr. Suga from School of Planning and Architecture. We must, at the time of planning itself, even RIMS also service is going upgradation. You must integrate digital infrastructure into the building prior to building being built. If I cannot have a very high-speed connectivity in the hospital, what's the point of going for e-health? Today in AIMS Guwahati, it's such a difficult pain process because lack of proper network that the patient can't get OPD to get the password to get OPD registration. They're just hapless. BSNL will give you a connection, but that's not going to solve the amount of data that are going to exchange in the hospital. What are we going to do about that? We must. We are working, sir. But I'm saying it's a pain point everywhere. It's not every hospital. What we have proposed under PM Divine, in fact, there's a scheme also we are applying in central government for that. Is that to correct all hospitals on a private hygiene network? When law allows you, why can't you use that thing? Instead of putting 50 crores, 70 crores, and 700 crores in hospital, put 20 crores more. Make the building smart digitally. Then only doctor's pain point will have. I have seen ESIC Dhanvantri not working. The moment you put the patient's name, the buffering will start. Does government doctor in OPD have time to wait for 20 minutes before something happens? No. We must invest money here. Secondly, I will like to work with all the hospitals. Every hospital, super specialty, should have a Section 8 company. Why? Because when we have new ideas, where do I test? If I don't test the technology in-house, I don't develop the standards in-house and I can't even patent. We must come with a solution. In fact, Ministry of Education has now given us liberty to all the central funded institutes in Northeast to set up a Section 8 company for research. Medical colleges also should, or maybe every medical college can collaborate with NIHFW to come central section. We do innovation here with a partner institute and deploy technology. Next. Geriatrics. We have already, sir has spoken, yes, sir has spoken about geriatrics care. But there is a silver lining here. The world's richest people are the people who, the bankers who own the pension funds. Today, Maharashtra, MADA, has a 20,000 crore loan from Canadian Pension Fund. I've been speaking to them that why don't you send 10,000 people to India for spending the sunset year of our lives in a peaceful place with good AQI. And what we should work on is dementia villages, geriatrics villages. You have trained nurses, you have nice homestays. This should not be in cities, it should be in very remote areas. Can we go to the next slide, please? And I'm very well close to this. Is Harsh Shringla, sir, our former sponsor and currently G20 Sherpa. ME is supporting me through this process. All I require is policy support from MOHFW. What are the guidelines to train geriatric caregivers? What are the standards of the housing in which we have to house senior citizens from outside of India? We can do two things immediately, and these are multi-billion-dollar industries. Is geriatrics care, where instead of sending a nurse, is no-brainer. But if we bring a family here, economy develops. Similarly for prosthetic treatment. Next. This is back one slide. So this is the first project sanctioned by MEA, central government funds. We're setting up a small innovation center on Indo-Bhutan border at PT. And what MEA has told that this goes big, then MEA has got a $40 billion kitty to fund this kind of initiatives. Healthcare is 10%. So 4 billion is almost 32,000 crores. They say you prove the pilot, we'll go it, but we'll not be able to do it alone. We need help of NIHFW and healthcare institutions to make it happen. So Moraine, Manipur, we have Tripura, you have Meghalaya, each of them have a border. Across, you see everywhere, treatment is very bad. India has much better treatment. Next. Next. I picked up this idea, madam. There's a dementia village in Netherlands funded by the pension fund. A small village. The biggest revenue emitter will be geriatric care, home caregiver. The richer the person, the more successful the person. 99% kids will not stay with him. Because of jobs will migrate to other places. And they will require assisted living in the sunset of lives. We don't have manpower today. Within India, outside India. We're talking about nurses and trained caregivers who can earn 2 to 3 lakh rupees per year. They can afford easily. We are developing on a cloud-based solution. It's in a prototype stage right now. Which, if anybody has a smart TV internet, all your BPA basic equipment can be advertised. You can pick up data. You can send, and it also has got a 8 camera sensor. There's a sudden follow of the patient. The camera will start and give video to the next of kin, son or daughter, wherever they are working. Because a lot of people die at home. They are fallen. There's a brain harm. There's nobody to take care of. My mother, she slipped twice. She is now having partial memory. Just slipped. We didn't know. The servant went to give her tea and they told the bhaiya that mother is, she is lying unconscious. This device is continuing to test on my mother at my home. But it helps me keep track of everything what she is doing. At least I know what's happening. If emergency, I can call up somebody to ensure that healthcare goes. Now, this needs to be done on a much larger scale. When we are training or making a course for geriatrics, we must include technology in geriatrics. That's the time that we start running much higher. And what is the market? Japanese, Koreans. We've been interacting with almost all the embassies, entire Europe. And you have a demographic, but where is your jobs? Not a 50,000 job, 2 lakh jobs. That's the thing. Northeast has amazing nursing capacity. I have some experience of interacting Sikkim, Mizoram, Nagaland. Amazing, good human people, nice people. In fact, New York, I was traveling, so the banker told that in New York, if you want to have a friend, keep a dog. You want to have good human beings, go to a small city or a village. You'll find human beings there. Here, everybody is because of money. So, geriatrics is something where compassion is required. It is something which is inbuilt into a remote area. When we give very successful, become slightly insensitive. But this is a benefit we should transform into economic opportunity, multi-billion-dollar opportunity. Next slide, please. Other area, madam, as a woman, all of you sitting here, I went to do a design project for cane and bamboo, but the way women work is only occupational health risk. Every woman in Northeast has a cut in the hand because they're splicing bamboo by hand. The same hand, they work in the paddy field, they'll cook food also, and every day do the same work. When they splice this, madam, this is cut. They have special cloths here which cuts, and it gets cut in 1 hour flat. They have backbone issues, they have arthritis issues by the time they become 35, 40. Because they start working with their mothers as they were 14, 15 in a village. We must do a study. And I did a small pilot where we took some doctors from Sabdajar. Next slide, please. Next slide. We gave them some basic kits. I went for CSR to Canada Bank and said, they were very good people. They gave me some money. Within a small village, we have given this kind of assistive kits to people. But we have 40 lakh women in Northeast. But you talk about net zero goals. We can supply furniture to IOCL, but why can't use money with different agencies to provide occupational health services to people? Factory workers, we must start teaching. In fact, the community health department of super specialty hospitals should be more proactive in community health reach. I went to ESIC, I was very disappointed. Very disappointed. We must strengthen our occupational health safety departments of big hospitals and integrate with the ABHA records, health records. We should know how people are getting affected by this, because it is, when we talk about gender inclusion into the workforce, look at the PT, this is 2024. We are talking about this year, the year of health. And we have a Vishwakarma scheme, but that scheme also missed out the health challenges faced by people. Every lady has a hand cut. We can give a hand at least got split when they work, or maybe change the equipment, whatever it is. I don't know the answer, but whatever was there, I could do it. I'll request that even in e-health records, we should do a special survey of these women and whatever it takes. Sanjit sir, please help us out with some money from IOCL. We should make it a successful project. You know, it's a service to humanity. So many women work on Northeast in this. Next slide. Thank you so much. I'm all done. And it's not my effort. It has been correct. I learned a lot. My experience with Northeast, I'm a better human being now. When you stand with the person in pain on the last mile, your whole optics change. When I was an urban bred guy, born brought up in Delhi, I met a lot of people, friends from Manipur, Nagaland, everywhere I know. Sikkim, 8 states I've traveled. I was very fortunate, and this team has been great support to do this journey. And why I'm very happy, when MEA said that, you know, they run programs every year, they said there's something very different. Imagine MEA giving us money for a small company from Northeast to give 80 programs across the world. This is a fact that we did achieve something. And life is ever ending and learning. You know, I'm so thankful to a lot of people. I heard Madhukar sir, I met an IHFW. Purani sir, why I tell him every time he's helped me. My ideas would not have been reality if he had not opened the doors of hospital. Loro sir, being a member of parliament, there were so many roadblocks. This project, one officer was not signing the file. Sir went as a member of parliament, sat in the ministry, got the file signed because next day was EMIC meeting and we had the election code of conduct. Thanks to your intervention, sir, that, you know, I was just a small fry in the larger ecosystem, but you made it happen. Our friend from NRL, he introduced me to the concept of Rubul Baruaji. Please give him a standing ovation. He brought to the notice of CMD that occupational health safety is a challenge. Refineries woke up. So we must act as a team, and I'm very happy that NIHFW gave us the platform. I came to about first time about E-Sanjeevani. I had no idea, ma'am. I worked so much, but you know, maybe my lack of knowledge, but you know, we run our 5G labs. We have got 10,000 students enrolled in our system. We can, through them, reach their families for enrollment. So with 10,000 students, we can reach at least 1 lakh people immediately. Thank you so much. It's been a very interesting journey. The caravan will become bigger and bigger with days to come. I'm very, very sure about it. We are meeting positive people this year on a new note. And by chance, I traveled with Nadda ji 2 days back from Guwahati to Delhi. When I showed this to him, the first thing he said, I kept mum. After 10 minutes, he said, Anand, give me your number. You must come and meet me. I said, you're spending thousands of crores in cancer hospitals. What about the pain of people? Technology should not be rude. Technology should be very humble to solve problems of people. Today, I find young people very rude when they're successful. You should be more humbler that you go, the more you'll rise in life. And we should all address, because when society's problem is solved, nation grows, we grow. We're all here because of nation, not vice versa. And in health ministry, I'm telling you, madam, you have done wonderful jobs. I have grown at a time where there was only tincture, that red medicine. Now you go and see in family care what facilities you have, and that's a massive change. And AIMS Guwahati is a wonderful institution. Not only AIM, Dr. Malia, a lot of doctors I know personally. Sunil sir, I would wish to love. Madam Geriatrics in Nagaland, always helpful. And politicians have to be made aware, sir, that, you know, Northeast should get away from this habit of roads, building bridges. As policy makers, you must direct the money towards this infrastructure. That's what going to solve your problem, not roads and bridges. Because connectivity is digital now. A person can work in a village and earn 1 lakh rupees, which was not earlier possible. In fact, next program in Mizoram is I'm working on the National AI mission to use AI to bring the best singers from Mizoram and make a world-class label from Mizoram. That's what we're going to do. Similarly, healthcare to data sets. Thank you so much.
Good morning, everyone. Sorry, I joined little late. And I also come from Northeast. And my association of Northeast is since 1986. Very long time. And I'm having my third tenure over there. Listening, Anand, was really thought-provoking. You know, how I think we all have a lot of life experiences. Imagine a person who grew up in Delhi and working in Northeast and falling in love with Northeast. It's because of he has element of humanity and human compassion. I think that makes a difference in your thought process, in your actions, in your feelings, in your deliverance. What he was emphasizing was use of technology. I think really the world has developed, but it is quite, you know, uh, there are larger section of society which is not really benefited of it, and we can make a lot of difference in their life. And not only that, he gave a global perspective also. We can make money. It is sustainable. Sustainable. You can really cure the people. You can really relieve their suffering. You can, take out their pain. That was the message Anand tried to give. It's really thought provoking. He really merged, the science, technology, and the medicine for the betterment of the humanity. Uh, and I would like to, I think next time we'll also incorporate people from the IIT so that, the technology and of course, we'll be starting a graduate program, 4 years graduate program, where 2 years course will be medicine, 2 years course will be from engineering, more emphasis is on innovation, the newer subjects like biotechnology, genomics, robotics, newer innovation of the instruments, and all this AR, VR, 3D printing, all those are integral part of it. So people based on their likings will be bifurcating and choosing in their final year. Somebody wants to go to work and just do the genomics, maybe the vaccine making, whatever may be. So it's going to be a really paradigm shift in the way teaching has been going on. Gone are the days when in the operation theater there used to be only surgeon and a statist and few people. But in today's time, you need a people from biotechnology, genetics, innovation, data analyzers, all those people. So kudos to you, Anand, that you have tried to bring a lot of like-minded people to the platform. And yeah, there is so much to be done for those people working in the, whether into the bamboo industry, whether into tea garden, whether into the, the cloth making, so many things. Besides giving routine clinical care and all those things, there's a lot many things to be done. Really very thought provoking, very impressive, Anand. Thank you very much.
Thank you so much, Anand sir. Dr. Ashok, thank you so much for this. Next, just giving you a small context. Mental health is the cornerstone of overall well-being, influencing how we feel and interact with the around the world. So, with this, our next focus is on AI in mental health. I really like to invite Shishti Srivastav, founder and CEO InfiHeal, working on deployment of AI in tackling the emerging mental health challenges.
Hi everyone. I'm first of all very honored to be a part of such a distinguished panel of speakers. I've heard everybody here, and I think Anand sir himself is such a prolific speaker. I thought I'll do it slightly differently. I'll probably ask a few questions along the way because I know that we have a house full of doctors. We have somebody who specializes in ethics of AI over there, and we also have several technologists and government officials. So I'm Srishti. I'm founder and CEO of InfiHeal. I'm from IIT Bombay, and I also worked as a Chief Minister's Fellow in Government of Maharashtra, where I worked for 10 tribal districts in Maharashtra. Before building this, I had my own journey where I understood the gaps in the mental health ecosystem, which I tried to address through what I've built using technology. So, if I really have to ask everybody here, what are the major gaps in mental health? I think the first thing that comes to mind is stigma. Mental health is a huge stigma. In fact, Over 150 million Indians struggle to access mental health care, but the economic survey says that almost 90% of the people never access it, never avail it. And that's a massive gap. And one of the major causes of that is actually stigma. But even if we set that aside, there are actual constraints in terms of the supply. We don't have access to, not everybody has access to hospitals. Only in big cities do you have access to mental health care. And most importantly, there are long wait times. If you go to any government hospital, you probably have to wait for a very long time to avail those services. And if you take the private route, you will end up spending around 1,000 rupees per hour. And you would need 4 such sessions to actually see any kind of benefit in a month. So 4,000 rupees per month is something that few of us can afford. Finally, misdiagnosis is rampant because of the fact that most doctors have to make a quick diagnosis. Often, personality disorders and mood disorders are switched, which causes a lot of problems. Okay, which okay, which causes a lot of issues. I hope I'm audible. Yes. So, which causes a lot of issues in terms of maybe getting the right kind of outcomes. There's also no mental health record. There's no centralized repository of records. So what happens is, if I go to a therapist, and if I want to change my therapist, let's say I move to a different location, or for whatever reason I find that I have a different problem and I need a different specialist, I will actually have to disclose my entire history again, which is extremely uncomfortable. As it is, there's stigma. We don't want to talk about our problems. So this actually compounds it significantly. We also find that there's a lot of good research happening, but it doesn't reach the end user. Why? Because in terms of continuing medical education, there's not much happening in mental health realm. So everybody has to do their own research. They have to do their own courses. Most of the courses are extremely expensive. So there is in general poor academia to industry transfer. So how do we address it? I think we go to the next slide. We address it by leveraging technology and leveraging AI. What we have done is we've built an AI therapist. It's called Hilo, and it actually shot to prominence when PM Modi mentioned it in his Man Ki Baat speech. We have been able to work with the government, especially Ministry of Social Justice and Empowerment, and we hope to also work with the Health Ministry as well as Department of Northeastern Development and Northeastern Region. So why do we think that AI can potentially be a solution? We think that because since COVID times, there have been greater acceptance of solutions like this. We found that a lot of people who would not otherwise take therapy began going to therapists, right? Also, we see in general a surge in use of AI technologies. Like more and more people are now using Chat GPT for their problems, which was not happening earlier. AI itself has improved significantly in terms of diagnosis and in terms of algorithms, and we find several notable use cases for the same. We also find certain supply side constraints, meaning that doctors can't service, they don't have the capacity to service the existing number of patients, and there are long wait times. So this makes AI a unique solution which can offer scale at 1/20th the cost. Next. So our solution actually involves leveraging generative AI using LLMs. So LLMs, all of us, I think we have heard of. Have people heard of ChatGPT? I'm guessing people have. So ChatGPT is sounds very fairly intelligent, right? But it has certain problems. It hallucinates, meaning that it doesn't give you the outcome that sometimes you request it to, right? Because ultimately it's a question of the data that's fed into it, right? So how do you solve that problem? You basically use your own data set, which is a proprietary data set comprised of therapy sessions. So that's what we've done. We're one of the largest repositories of therapy transcripts that we added to generative AI to get an output which hallucinates much lesser, which has made AI much safer. And we also use a multi-agent system. So multi-agent system, not to bore you with the technical aspects. Single agent systems are capable of handling a specific type of a use case, a niche use case. But if you have something as complex as mental health, where in fact people don't even know whether they want to vent or do they want a solution. A lot of times when we talk about our problems, we don't really want a solution. We just want to be heard, right? And sometimes you do actually want somebody to proactively give you advice. So how does an AI distinguish that? And how do you design flows that actually accommodate both those aspects, right? So multi-agent system is something that's absolutely necessary to accommodate for the complexity of AI. We also have something called as graph rack. Graph rack is a fancy word for a retrieval mechanism. So it's able to pick the best use cases from the data set. And because it's able to pick the best use cases, it's able to provide a very hyper-personalized kind of a solution, which mostly other platforms or other solutions cannot. There's also therapist alignment. In fact, we have our therapists in-house here today. Our team has actually built our data set from scratch, and they have actually worked to fine-tune and validate the data set as well. And finally, you need guardrails. What if somebody who's suicidal actually comes on your platform? What do you do then? All of these actually raise some ethical questions, which I'll address subsequently. Next. So what we do is we don't think AI can be a standalone solution. I think that they are humans that are needed in every step of the way. Wherever affordable, we can match people to therapists, which is also what we do. Anybody who comes in with any clinical diagnosis like ADHD, autism, OCD, they are matched with the right therapist for the needs based on their conversational history. People who are suicidal or who are having a psychotic breakdown, they are actually connected to distress helplines. AI doesn't actually deal with those cases. But when it comes to low risk cases that all of us actually go through, work life balance issues, parenting issues, academic stress, even relationship problems or loss of a loved one, things which are relatively universal but not clinical in nature, that's where AI actually is capable of handling quite a lot on its own. Of course, with certain guardrails and safety mechanism. And what do we do? What do we do for each of these cases? For low risk cases, we can easily provide people with a bunch of exercises, meditations, guidance, counseling, and AI can even act as a sounding board because it has the data fed into it, which is built by therapists. But when it comes to high risk cases, that's where we provide people with a safety plan and match them to distress helplines right away. Next. So this is our product. I don't think we'll have time for the demo, but we basically have an AI chatbot. Think of it as an AI chatbot that's voice enabled. It can talk in 93 languages, and you can type pretty much anything that you can think of, and it's capable of handling any and every query around mental health and around sexual health. Aside from that, this AI actually also is capable of matching you to therapists when needed on its own. It's able to infer what you need and it matches you to the therapist appropriately. It also has an SOS button, kind of like a distress helpline, to connect you in moments where you need that human touch. And then, of course, it has a community feature where it's kind of like Reddit, but it's peer and moderated and psychologist moderated. So psychologists actually see who's posting anonymously. What if there's some red flag, there is an escalation. Next. This is our team. So I'm Srishti. I'm the founder and CEO of IIT Bombay. My co-founder is from Boston University, a CS grad from Boston University. We have Professor Sujan Anthony from Neemhans and Professor Prakhar Jain from Bombay Hospital as well. And Jasdeep Magu, who is a neuropsychologist, and as well as a board of psychologists who are present here today. Next. So far, we've had over 1 lakh people on our platform, and we've seen a fairly high satisfaction rating of 91%. 91% people who used it found it useful in either symptom alleviation or mood improvement. And we've partnered with, of course, Ministry of Social Justice and Empowerment, primarily NEPED and all the CRCs, and NIMHR. We also have partnerships with NGOs, hospitals, as well as academic institutions. Next slide. So there have been a lot of research that have been done. More specifically, we have studied how AI actually works in EAP programs, employee assistance programs, and that's where you get a lot of low-risk cases, and it can be extremely useful. It's also extremely useful in case of dealing with disabled population because it provides a ready tool that people can access 24/7 without having to move much. We also are doing our own research, which is chatbots as a tool for psychoeducation. Next slide. This is just some of our highlights recently. PM Modi mentioned us in Mann Ki Baat, in the 108th session of Mann Ki Baat, and he highlighted the growing mental health burden that India might be facing and how tools like ours actually can help bridge that gap. We also, this is our MOU signing with Ministry of Social Justice and Empowerment. We've had some prolific people who have endorsed us. We've had Jensen Huang, who's the founder of NVIDIA. We also had Jackie Shroff and a few others who have endorsed our product. So yes. Next slide. Yes, some of our industry partners that we are currently engaging with. You have Google, you have Nvidia, you have Microsoft, Forbes, etc. That we are working with, and we hope to work. Firstly, have workshops for the Northeast where we focus on awareness generation. I think that's the first step, and secondly, maybe enhance the adoption of tools like this in a way where the community is actually participating with full force. Thank you so much for this opportunity. Thank you. Thank you.
Thank you, Srishti. The purpose of asking her to speak is that we are running some workshops with the colleges already. I will also request our representatives from three major medical colleges in Northeast, in fact, four of them. So, AIMS Guwahati, RIMS Imphal, Nagaland. We have from Dibrugarh and Guwahati also here. What I would request is that why don't we use this tool to run a program for families affected by cancer? See how it responds. You know, my study when I was working on cancer said that a lot of cancer patients, because they become economically drained and there's no hope in life, they commit suicide. The family doesn't even report suicide because it's a stigma on the family. They don't even write in a medical death report like that. For humanity's sake, at least we can do a try. Because someday everyone will get old. Somebody will get sick. We should run this program. Secondly, please make a note of there is a fund called Senior Citizen Welfare Fund. This fund was created by RBI. There was a 15,000 crore rupees fund lying unutilized in RBI and dormant accounts. They seized the account, and the interest money has been transferred to an account which is called Senior Citizen Welfare Fund, where you can seek money for different interventions for senior citizens. Today, when people are having early onset dementia, it causes loneliness. When you don't have kids with you, emptiness syndrome. You groom up a kid and then the kid goes away. When you want to talk. When my father was diagnosed for cancer, he's a very advanced stage now. When I went to consult the doctor in AIMS, he said, if you want him to be happy, talk to him. And I started talking to him. A lot of things which I was taking for granted. He had a bucket list of things that he wants before he dies. What I need to do for her mother, how I have to keep her, what she has to, everything was there, which he was hesitating. And mental health issues, imagine it's happening. I am very successful. My father is from WHO, he's a doctor himself. Still, it's happening to him. Imagine in villages what's happening. In Sikkim, I went that dementia is happening at 55. Why don't you use the Senior Citizen Welfare Fund to deploy pilot projects to each of the hospitals? Money is not a problem. So my request is that Srishti, you please do a workshop in every state of Northeast with the relevant medical colleges. We'll also take help of Sakshan platform to create awareness. And we should have, people who are tribal students coming to big cities. Cultural adjustment takes a lot of time. IIT students are committing suicide. Adjustment issues. We just can't brush it under the carpet. There is no mental health issues. And more we go on this, more we are lonely. Imagine, this is the biggest killer. It's so intoxicating. It alienates you so much that the human touch goes away. And the cost will be very high for society today. We are not analyzing the cost of society. The depression pills, drug addiction, what is that? And you don't even know what the child is doing on this. So I think we must train our trainers in a way that we should use technology to screen people. Let's begin with all the hospitals which are here, just help us. Let's do a pilot. If the results are good, and parallelly, we can all do a common meeting with Ministry of Social Justice. Rajiv sir is my former boss, also when I was in MCD, he was my boss, he was MCD commissioner, now is there. We are having tomorrow representatives from the tribal sub plan. He is coming, I have called everybody. Tribal sub plan is a budget where there's so much of money for tribal areas, and most of Northeast will fall into tribal category. I have specially called them, the entire team is coming tomorrow. Why don't we ask 100 crore rupees? We can distribute it 10 crores to every of the medical colleges, and she can be there. We can do a wonderful program. It is something which is selfless. It's not going, everybody is going to suffer someday. We're all going to get old, sir, right, sir? Someday. And how lonely we are. But if I don't go out, at home there's so much attention. When I go talk to people, it relays me up. This cannot solve the problem. When doctor told that if you don't touch your father, or if you don't give tea to him, you don't talk to him, he'll die early. So human touch is very important. AI will help us to diagnose the problem, then we need to talk. But because we have very limited psychiatrists and technicians, you have only one LGBI in Tejpur, you must use technology to screen large population. It's not only rich, sir. Women whose husbands go away for work, migrant workers, both sides are getting affected. People staying in, if you go panchayat after panchayat in Uttarakhand, it's only senior citizens, nobody else at home. All the people are migrated away. There are issues that we must address with everybody, and everybody has to come together. Lawmakers, Saksham, are good doctors out here, and this is something selfless. It should for society. There's no profit and loss account here, but this is something what we all need. And Shashti, you must work hard. Bombay girl, you have to work very hard. The plane has to, the rubber has to hit the road. So please go with your team, and you'll go to Mokokchong where there's no road. Deliver in field there. Madam is there. She'll take you there. Sir has, in fact, Manipur is very important because there are so many displaced people. The families must be going through some trauma issues. Another very ideal case. We must do that over there. So please, it's a lot of burden on your shoulders, and that's why I invited only you as a startup. You have addressed something core to my heart also. Thank you so much. God bless you.
Thank you so much, sir. Thank you, Srishti. So now we are going to take a break. So let us have a break for lunch and return by 2 p.m. for the afternoon session. Thank you. to improve medical teaching and start courses on technology ready manpower for emerging healthcare needs for the global south. So kindly be on stage.
Good afternoon.
Rapid introduction is enter. Is it working? Okay. Okay, welcome back after nice lunch, and the Delhi weather is really very, very nice, very romantic, I must say. Okay. It's not so cold in Guwahati, but yeah, weather is perfectly fine. I'm loving it. So we come from Guwahati, and I'm his boss, and he's our learned faculty in the Department of Orthopedics. I'm blessed to have a lot of young minds over there who are really energetic, enthusiastic, modern thinking, ready to do, and they just need a guidance, what we want to make out of them. I think they are really, they dedicate, and we are there to show them a little bit of path and a little bit of direction. I mean to say, keep the motivation alive, make them more energetic and enthusiastic. Dr. Malaya comes from South India. He was trained in Davangere.
KFC Mangalore,
KFC Bangalore.
under Manipal University.
Manipal University, and orthopedician by profession. And he's got a innovative bent of mind. And I must request everything in today's time, if you are not creative, if you are stuck in just your old learning, this is the era where you should be learning, unlearning, and relearning. The people who are not relearning, I think they are really doing very poorly. So I find a spark in him, and when I came in contact with Mr. Anand, we visited the facility over there. You see, gone are the days when people used to survive for 70 years. Now we all will be living, your generation will be living 100 years plus, maybe 140. And during those duration, you can have 4 jobs, 4 times pension, maybe 4, 5 marriages also. This is possible, when you have got a very longevity of life. No, I'm not talking, this is written, this is research, this is published. So the coming era belongs to this nanotechnology, genomics, bionics, biotechnology, and the 4D printing, AR, VR, meta. You will be experiencing everything in the metaverse. You will have a kind of your digital twins where people will be able to create your duplicate, and they can experiment everything on it with what is good for you and what is not good for you. So the precision medicine is on the way, but let me focus on this thing to the orthopedics, where this 4D technology, 4D printing is making so much of difference. When we cut the bone, we need to replace it with titanium metals are there, and with the 4D printers, you can really fill the gap. And it was very challenging earlier. You can practice surgery beforehand by this virtual reality, and then through this CT scan pictures, the printer will be able to make the real size, precise, and that's what Dr. Malia did in one of his case in our center. Though we have very few surgeries performed, but adopting the newer technology is, I think, is the message of the day. Over to you, Malaya. Okay, otherwise I think.
Thank you. Yeah, good afternoon, everyone. First of all, let me tell you, it is about healthcare solutions for bridging the gaps. We are from, we are from medical field, but most of them, see, to talk about a company like Amtron, I didn't even know that there is a company called as Amtron, and which is there in Assam. Yeah, before July 2024. So that's what, and then we got to know, and then what happened, I'm just going to explain. So
So first about the case, how it started. So yeah, in like a 23-year-old male, yeah, he had swelling of left wrist and pain in 2021. So that time what happens, he goes to a local hospital there in Guwahati only. There they do biopsy and they found out what tumor it was, answer tumor, and then it was treated with the tumor excavation. You can see that tumor there, it was removed and then the bone cement was placed along with the screws. And let me tell you, those screws were stainless steel. So why? What happened with that? I will let you know later on. So that was done. But for 3 years, the patient didn't have any swelling, nothing. Okay. But in July 2024, May 2024, this patient came to us, and now here you can see the tumor has recurred. So now the problem is, it is the bone. You can see there, it is very thinned out, like on the posterior aspect. So now we can't do anything. We can't salvage it. So now that entire tumor has to be excised. Now what? After excising what? So like in literature, there are options like yeah. First thing is you remove the tumor and the ulna which is there. You put it in that place of radius and then do arthrodesis. Arthrodesis is the fusion of the joint. So after that arthrodesis, patient will not have any movement in the joint, in the wrist joint. Another option is you take the bone fibula from the limb and then you place it over there and fix it. But here the issue is already it has recurred once. You are putting a patient's own bone there, autologous bone graft. But what if it recurs again? So even that bone also will get affected. So now we had to go for a solution, something like a prosthesis placement, which will act like a spacer. Spacer means it will be there. You can observe whether it will recur or not. Okay, and then if it recurs, then you know, okay, it is a process. But patient's own bone, like fibula or anything, will not be affected. So now what happens? In May, we got CT scan. Also, we got CT scan. We could do, but always like whenever there is a tumor, we do MRI. But here there were stainless steel screws over there. We couldn't do MRI because of this. But still, the tumor was not salvageable. We know that okay, it is like it has to be excised. So then in July 2024, we were invited to Antron company. There we saw everything and we got to know that, okay, this is the company which can do this, can solve our problem. So then, so this was designed and I'm telling you, they are so quick and so like on time. I'm telling you first, I had a Skype meeting with one of their technology designer. I told him everything, and within 15 minutes, he understood the entire thing. Okay, and then within 1 week, they gave us a replica. Means it's a prototype which is made up of plastic, just to say that how is the design and all. So how we got this? Because from the CT scan. From the CT scan, we got the measurements. How long is the tumor? What is the thickness of the canal? Everything from the CT scan we got it. Now we have to we asked them to prepare a process. So first they gave us in a plastic form. So it was completely brilliant. It was like almost 99.9%. It was perfectly fine. So then I told them, you go ahead. Now we want to make a titanium process because if you do stainless steel, then we can't do MRI. If any in future, if you want to do MRI, we'll not do. So titanium. So titanium process was designed, and this was the one. So the idea was to excise the tumor, and in that place, we'll fix this prosthesis. And the prosthesis also, and the distal part, there are holes, suture holes. So these are like there are ligaments around the wrist, so we can reconstruct the ligaments and fix it to the process so that there will be stability. Patient will have movement also, not like in arthrodesis we don't have. So we can do this. So with this 3D printing, see, so much of things were done. So then, and this is the distal part, the articular part where our carpal bones, this scaphoid, lunate, and all will sit over there. So with this 3D printing, it was like completely perfect, 100% it was. And the bones, like when I was operating, I'll come to it, the bones were sitting so fine and so perfectly fitting it was, even the movements and all we saw. So then, yeah, this was the, in September, the process was handed over to us. Then we went ahead with the surgery, but the tumor was excised. So now you see there is a gap there. So in that gap, we have to fix. So from the CT scan itself, we got to know how much is the tumor length, and also we got the measurements. Everything was fine. So with that, then you see in this picture, there are the suture which are placed in those suture holes, and then the process is perfectly fitting in place. So this was the X-ray after the surgery. You can see this, okay, and even the stem part, it is in the canal. The proximal stump, it is there in the canal, and even the lateral X-ray there was perfect. There are ulna also, it is well in place. Patient had good stability. Post-operatively, he undergoes the same rehabilitation, physiotherapy. So now, thing is, now this patient, 23-year-old, as I told you, it is always a teamwork. It is not like only a orthopedician will do everything. It is like we had a team of anesthesia, plastic surgeon, okay, and even radiotherapy also. Post-operatively, we have to do radiotherapy, pathologist also, because so this was the entire team who was which was involved. So the teamwork. But now say that this patient is a 23-year-old, very poor patient, like a poor background. Now to get a titanium implant for this patient, titanium implant to prepare it, it costs around for this. It is as per the grams. That's what Anandji had told me. Like even the amount, this thing, no, the titanium material. So it is as per the grams, how much grams it is, and finally it will come around 50,000. But for this patient, it is very poor. But see this in Ayushman Bharat scheme, you can see there is one complete package. I'm thankful to the person who has done this because he has understood that future there is that 3D printing is going to happen, and he has done prepared this, and this was in 2017 when the Ayushman Bharat came. So here you can see there is a code. Now there you can see that 92,300. Like there are tier 1 city, tier 2 city, and also now for the tier 2 city, which is Guwahati, it is 92,300 is allotted for the surgery itself. Plus up to 150,000 is for the prosthesis. So entire thing, entire surgery got covered under this scheme for the patient. He had Ayushman Bharat card, entire thing got covered. So now, if you see this, we had 3D printing also plus support from the government through their schemes. So this was one of the like all solutions getting all problems getting solved at once. So because of this. So now one more thing, it is not only about orthopedics. Like if you see about dental, now I was seeing that outside. So they also have some solutions like with 3D printing. Even my wife is also here, so she is doing audiology in AIMS Delhi. She's working there. So she is also like into this 3D printing and all that. Now you see that hearing aid devices. So now they are also into 3D printing where they take the measurements of the inner ear and they prepare the hearing devices. So she also told me like I'll not name the person. At once a chief minister had come to AIMS Delhi for this thing for testing ear testing, and it was found that he had a bilateral moderate hearing loss. So he was advised a hearing aid. So, but he told नहीं नहीं मैं नहीं पहनूंगा because लोग समझेंगे कि मैं पहन रहा हूँ. So now even you see like people also have become fashionable. Like they don't want that. They don't want people to know. So now this inner ear thing is there. So it has advanced a lot. Now people want more solutions like with 3D printing, you can have this inner ear hearing device, even with the dental also. They can prepare the molds and with 3D printing, which will match your uh, yeah. So that is what it is like a 3D printing is like for our AIMS Guwahati now, and with the support of Amtron, and it will be a very good partnership, I believe, and in future also. This is one of the first case, but we have shown it to people that okay, this can be done, and it can be done in other centers also. So with this and with the support of government also, so we will be doing more cases. That's what I have told Anandji that we need his support. And this was our entire team where there is anesthesia, plastic surgeon, everyone. So thank you.
Yeah, the kind of coding, rather coding was devised in other industries, aircraft industries and all the factories, all the functions done by the human being is now done by the printer, by the machine. You remember that Japanese Prime Minister was shot by a shotgun, and that shotgun was made homemade in Japan by that guy, and it worked. So the 4D is a kind of a magical machine through which the productivity, the whole industry is automated nowadays with the robotics and the 4D. You don't need a human. You just need a human like a supervisor or a production manager or something like that. So the whole job in today's time is done by the machines and the robots. And the 4D printing system, especially in the field of medicine, dentistry, orthopedics, any cancer surgery, any kind of replacement. The medical science says that by next 20 years or so, we will be able to replace almost 90 to 95% of the human organs. With the regenerative medicine integrated into it, there is a cell in our body which is called a pluripotential stem cells. Those are extracted. Like in today's time, how you are treated for leukemia, your whole umbilical cord blood is saved, and then it is grown, the cultured, and it is grown, and bone marrow transplantation is done. Your own cell grows, and then it is replaced. So with your own pluripotential cells, people are developing artificial liver, kidney, heart, intestine, everything. People have so far made trachea, our breathing pipe, that inside the kidney we get another pipe called ureter, so we can urine comes to the bladder. So people have been able to make trachea, there's urinary bladder, all kinds of replacement with the bones, and soon we'll be able to make those organs also. Brain is a bit complex task, but people are expecting human body transplant also. They'll be able to have a face transplant and everything. So the way technology is developing, we need to adapt it, we need to know it, and soon you will be witnessing it. So thank you, Dr. Malia, for a wonderful speech and the live example which you have set up, how industry should be collaborating and adopting the technology. I had a experience of this 4D printing when I was training in Thomas in Melbourne, Australia, way back in 2004. There was a neurosurgeon, and he was very fascinated with this 4D printing. So we used to get complex pelvic fractures and Paul Divo. He's got 200 patents on this thing, and I'm sure you also have some patent related novel ideas. So he used to give us those 4D pictures that how what is the extent of the disease and how we are going to sort it out, how we are going to repair it, where it requires a replacement and all those things. So my exposure goes very long way back, and I'm really very very keen to spread this message and knowledge that we ought to be adopting the newer technology into our day-to-day practice, whether it is in home, office, hospital, and in healthcare, everywhere. Thank you very much. Somebody talking on AR here also?
I'd just like to add, sir, on 3D printing. Okay. I just have got confirmation from Japanese government. They want to develop a pill which takes care of all medications in a day.
Okay.
So it's a hackathon kind of challenge. So senior citizens end up popping a lot of pills because of comorbidities in the later part of life. And generally, like what I see with my father, that he looks at the color of the medications and sometimes it's double dose or something. Very common. So it's a one pill which has to come, all materials will come together and will dissolve as per a timer.
Yeah, so it's
So that will be a great application of 3D printing where, researchers and we can all work together. This project is called Society 5.0. So it's beyond 4.0. It's a Japanese funded project.
so this people take usually aspirin, nitroastatine, and some nitroglycerin of some blood pressure.
That could be a very good use case where all of us can come together. See, imagine the carbon footprint of printing so many medicines, making so many medicines, packaging, transporting it to CGS beneficiaries. If all CGS beneficiaries only get one pill in a day, it will be a national saving. And counterfeiting will be very difficult.
Okay.
So that is one area we was all work together, Society 5.0.
Okay. Very good. The small. Another I would be very happy if you would start printing dollars. Then it's full of dollars. Dr. Malia, please. He's a champion doctor. You want me to continue? Malia, 3D printed cake. The map of Northeast. Thank you. The 3D printed factory. For metal printer. अभी नहीं नहीं ये अभी मैं
Thank you so much, sir. Now we have our guest, Dr. Sheila Mishra. So I really want Laura sir to please facilitate, ma'am.
Sir, you must be on this.
पहले आएगा कि नहीं वो मतलब पहले सुन लेते फिर डिसाइड करते हैं
We'll carry back Northeast with you. All the 7 sisters in the map.
Wonderful. This thing 3D printed.
Yes.
Appreciate.
Thank you so much, sir. Now we have Dr. Sheila Mishra with us. She is Dean Faculty of Science, University of Lucknow with us. She will be speaking about data analytics, which is in trend, and its combination with healthcare. Ma'am, stage is yours. Very good afternoon to all of you, esteemed dignitaries, whom we were learning, from which we were getting inspired and enlightened on the thematic event, and all delegates and the guests. I'm really honored to be here among all of you on the invitation of Dr. D.K. Yadav, and I'm really proud that he is doing his job very well by bringing everyone together for the service of the nation and doing good to humanity.
Before I start, I would like to share my personal experience because it relates very well with the event and the kind of work you all are doing. Last year in Shivaratri, I just out of curiosity, there was a very small lump in my breast, and I thought it was there for very long, and I was just not worried about it. But since my son, my husband, and there are so many doctors in the family, I went for further investigations. And to my surprise, for my surprise, otherwise it is not very uncommon, it was malignant. I went through all the procedures and everything, and the therapy started. And as we know, the disease, the malignancy, or the carcinoma is not a big deal nowadays. It is treatable at the early stages. But the way we have the side effects of the medicine and to handle them and to bear with that for the family, for the caregivers, as we have been hearing from many of you, is not easy. But there was one thing from somewhere in me. I was a little worried because of very few reasons, but excited more than that. Excited more than that because I have been looking into a lot of medical health problems as a data analyst or as a statistician. This was the opportunity for me to have a first-hand subjective experience which could not be shared by anybody else. And there were many hidden variables on which data is never collected. And whenever we are treated by the doctors, there are very limited number of investigations. I will still say limited, though there are many, but it's still limited because there are many factors which are operating when you are going through all these treatments and your family is going through that period. And I was excited because I was somehow into, like, very much into Indian knowledge system, into the meditation, into yoga, into naturopathy, and all those kind of things I have studied, I have practiced in my life. So this was the great opportunity to test all those things during this period. And believe me, my opinion was that I won't go through the procedure, the standard protocol. I wanted to try all those procedures on myself. But my family was adamant. I had to go under the protocol, whatever was a standard protocol. But I said, permit me to do the way I want to conduct my life, and I want to try something else also, which is not in interference with those things which are being followed or which are being advised by the doctors. So during the chemotherapy, I was taking all the help from Indian knowledge system in conducting my lifestyle. The walking of the barefoot, having the sun, morning sun, and then doing the meditation, doing the yoga, reading the good literature, and talking to the positive people, not talking to anyone who was trying to be sympathetic or something like that, any opinion or all those things. I just cut off from all those people and never spread this news that this is happening to me because I was just not bothered about it, and accordingly my family also took it that way. And then I found just after 6 chemo sessions, the tumor was gone, everything was clear, there was no trace of anything else, neither in my mind nor in my body. And then doctor was amazed. They had to go through the earlier ultrasound reports just to find out where to do the surgery. Within 3 months. Within 3 months. I won't say I was not going through the standard protocols. I was. I went through surgery. I went through radiations. But during all these procedures,
one thing could not be impacted was my mind, my mental health, my psychology. And that was the most important thing because that is where any disease impacts so hard. Because you are in a very different type of mindset at that time if you are in a regular mindset. Now, coming to the actual theme of my talk, the big data analytics and digital health. When I was going through this process, I was having sometimes side effect my eyes, sometimes on my teeth, sometimes on my gut, sometimes on my limbs, nerves, everything. The whole body system was impacted like anything because of the side effect of the drug. And when I was going to my oncologist, he would say, okay, you are having problem in eyes, go to the eye specialist. When you are having a problem in liver, okay, go to the endocrinologist. And I needed one single platform where all these kind of things are brought together and one single diagnosis or course of treatment was given to me. It was just not happening because nowadays, if you have like problem in the left eye, you have to go to the super specialty of the left eye and then the right eye. I mean, it is coming to that extent. See, all the body parts are seen like a separate thing. And without this kind of digital intervention or the big data analytics, there is no expert available who can understand all the nitty-gritty technicalities, medications, and the impacts on each part of your body. So if there is this kind of facility, this IA available to us, AI, artificial intelligence, it can integrate whole lot of variables, their patterns, their conclusions, everything at one single platform. At least your main doctor can look into it because they are the expert of their own field. Surgeon will perform surgery and then go away. For medicine, he will say, I'm not the expert of, go to the oncology medicine. Okay. So I was just like feeling, am I a single person or I am a collection of all these parts? So if such kind of facility is available to us, and now I'm trying as a statistician, how can I bring all these things together? Because it is the academician, researcher, and a statistician who will write the protocols for the artificial intelligence, which the practitioners will be using in their day-to-day practice. So this is one of the things. Next thing is that I was hearing that lecture on the psychology that was very interesting. The mental health. Health is a component of, as we all know now, it is having many dimensions. It is just not like physical aspect that surgery or anything which is related with the organs. Health is you have to be socially healthy, you have to be mentally healthy, you have to be spiritually healthy, psychologically healthy, economically healthy, so many dimensions of the health. And as many dimensions of the medicines as well, they are available. Now we are talking about statistical medicines as well, spiritual medicine as well, along with all those the branches of the medicine. So statistical medicine means when you are conducting the trial on 50,000 or 1 lakh people, and you are generalizing it to the individual, where the first principle in statistics is that the results of the groups are never applied to any individuals. But unfortunately, in the medical and health sciences, individuals are treated, not groups. The medicine is being taken by the individual, and you are applying all the ranges of all the body parameters according to whatever was tested on a group. Maybe that I am feeling healthy with even beyond the value, those ranges, because there are extreme values always in the normal curve. Even if you are using 6 sigma limit, at the extremes, there are people who will feel healthy even if their parameters are much beyond that. So individuals have to be treated like individuals, not as a group. And in that situation, this thing, the digital health mission initiative, this is going to play a huge role in that dimension, because here the data is being collected for the individuals over their life period. And now if that is available on the cloud, then any person who is the consultant for that
particular individual, they can go back into the data which is available for that particular individual, how the individual was responding during different phases of life, during different phases of the disease. That will customize the medication for or the treatment or the therapy for the individual. So in that way, the programs are to be written that way. Like here, if we just exclude the academia or the researchers, the theoreticians, then the purpose is just not going to have that much impact as it would have when we all are coming together, because it is a whole life. We do not uh, go through this life in different dimensions. We are not like professor at one place, mother at the other place, then somebody neighbor at other place. No, I'm a single person. I'm a single person. And do you know, like the best indices of your health are the feelings. The feelings are the best indices, though you don't know how to calculate that. If you are hungry, no matter how many parameters you are having, nobody can tell you whether you are feeling hungry at that moment or not, except your feeling that you are feeling hungry. If you are feeling loved, that is the only indicator that everything in your mind is perfect at that particular time. You don't have to consider 100 or 1,000 variables to integrate them and tell anyone. That means we have to work upon the feelings, emotions, and the mental health the most. Because even if all other health infrastructure is available to us, unless we are mentally capable of taking the best out of it, we won't be disciplined by the regimen which is being prescribed by the other people. We won't be in that kind of mindset, or the body will not be responding that way. But again, here I will come back to the Indian knowledge system. Indian knowledge system tells us very well that we live in 5 sheaths. It's not only the physical body we are talking about most of the time whenever we are talking about health. Of course, that is the foremost and very important thing by which we work, by which we come and interact with the people. But with this comes the inner layer of the vital force. And the vital force is again taken up by the higher level of your mental force which is further in intellectual force, and that intellectual force, that is the real you, the self, the consciousness on which a lot of studies, researches, and everything is going on, especially in the developed countries, because they have understood the value of all these kind of understandings in making our life and the quality of life beautiful and wonderful for all of us. So I would like here to invite all of you to look health and to develop the digital health technology, not only from the point of view of the outer layer of the human being, but also for the inner layer, especially the mental health, which is based on the Indian knowledge system. Because most of the time, the tools which we are using for mental health, or the kind of therapies, CTBT and all those things, which we are advising to our patients, the Bhagavad Gita is having everything into it. I mean, India is such a vast country. If you just take one of the shloka, and then you will understand it is very well written that your mind is your best friend and your mind is your worst enemy. Are we dealing with these kind of wisdom whenever we are providing the mental health solutions, or we are simply telling as what we have learned from the Western authors? Western authors, I have come across many things. I was there in USA for 2 semesters visiting assignment, and most of the time my students were coming with the complaints that they are not in that mental status even to give sometimes assignments, sometimes to appear in the examination and all. I was taking regular weekly mental de-stress classes with all of them, and it was really becoming so popular. During my 1 year, I never had any Saturday, Sunday free for myself. I was always speaking on different platforms, and they were loving it because what I was talking was from the Indian wisdom, which they can take control of. It was not in the control of some other person. So it was handling your own self with the help of that information, which is already available to us, but we never bother to pay attention to that. And during all my journey, I never felt any time any kind of stress because of my disease. I know that people have that kind of. I was doing my job. I, as a dean, there are many departments under you. You have to conduct a lot of activities. Everything I was doing, just it was the physical kind of weakness whenever I was having. Then only I was resting. So the thing is that when we are developing the digital tools, we have to take into consideration the integral approach, the holistic approach at all levels. At first level, when you are giving solutions for the physical body, then you go to the next level. Maybe there is a group of people waiting for the next level of social relationships. Biggest issue. But the challenge to handle that is already available to us. Are we providing those things through our digital solutions? We have to look into that. And then again, the consciousness studies and other things that also we have to take care of. So holistic digital health, that is the kind of future, and we look forward that we get it. And the challenge in front of statisticians and the data analytics is to develop those type of technologies, the softwares, the apps, so that it can reach to the remotest areas, and it should be like available, accessible, and affordable to anyone and to everyone across the globe. Also, if we are using the things which are developed earlier somewhere else in the West, as has been pointed out by Mr. Anand, we have to pay a lot of money to them. And when we have indigenous solutions, why not to use them? So with this, I would like to thank each and every one of you with this invitation that you are most welcome to come to University of Lucknow. There we have a very nice team of the scientists, the people who are really interested in working into all these areas as an academia. We have, like in the 5 districts, the youth who can be connected as your brand ambassadors for these digital health programs, and they can really spread this message across the length and breadth of their state or country, wherever they are moving, so that we can take this program forward and we can realize the dream of our Honorable Prime Minister, who has taken Panchpran also to improve our indigenous implementation in the innovation, research, and everything, and to have a Vikasit Bharat by 2047. Thank you very much. Thank you very much.
Yes, please.
What actually you meant by the word Indian system of medicine?
Indian
System of medicine that we talked about.
Well, the term I would not like to use exactly as a Indian medicine, but the thing is that, like in yoga, when we call, just we had the first international meditation day as well. So yoga, all the Ashtanga yoga, that is also very helpful in handling all our affairs, be it physical, mental, or social, like yam, niyam, asan, pranayam, pratyahar, dharana, dhyan, samadhi, Ayurveda, then Indian way of thinking, like we are here to serve. Our basic fundamental philosophical principles are: the world is not existing in isolation. It is like a collection of everybody together, and when everyone is happy, healthy, then only I can also remain healthy and happy. So before thinking about myself, if I think about others also, each and every behavior of my life, how it is impacting others, if that kind of thinking philosophy, Shad Darshan philosophy, if we are into that, then, and the climate issues as well. In Indian system of thinking, the climate, like we always call Dharti Mata. So when you establish a relationship with any of the natural elements, you will not exploit it. You will use it. Ishavasya sarvam yat kinch jagatyam jagat. Tena tyakten bhunjitha ma grada kasvidhanam. The world is now trading on two attributes of human weaknesses, that is greed and fear. India or Indian medicine I won't call, it is the way of life. It works as medicine as well. It works as medicine as well. So if we think that we are a part of a whole system, and if the system is good, we will be good. If the system is happy, we will be happy. And we have to conduct us in that way that we don't exploit anybody, anything, any natural element as well. So this is what, like Ayurveda and philosophical Shad Darshan and Vedanta and Upanishad, they have a lot of insights into what we call Indian philosophy. That's it, sir. Thank you. I'll be happy to interact with you more, if not much during this session because of the paucity of the time. But afterwards also, I will really be happy to connect with you and learn from each other so that we can make this world a better place. And one thing is also, as Swami Vivekananda used to say, that divinize your relationship with the human, and with the divine, you humanize your relationship. That means everything which is divine, you just feel like they are your brother, mother, father, like that. Then you will be happy. And with your fellow being, if you divinize them, that they are just like God to you, then you will do your best to them. So if these two things are taken care of, I think we can do really good. Thank you.
Thank you so much, ma'am.
If there are more questions, you are most welcome.
Thank you so much, ma'am. That was really inspiring for all of us.
Full screen कर दो। So very good afternoon, and it's a really great privilege for me to speak before my teacher. So thank you so much, ma'am, for making me like this, or making able me to stand before you for organizing such kind of events. Thank you so much for what I'm today, just because of your guidance and motivation. So, so we have talk about various sessions about the Saksham portal. So Saksham is stimulating advanced knowledge for sustainable health management, right? So Saksham is to capable, or to make the capable, who is capable enough. This is the Hindi meaning, and we have formulated the Saksham in such a way that it also having the name in English, right? So so recently I become a father. So ministry, many people say that now you become the father, but I told that no, Saksham is my first baby. So this is my feeling about this portal, because I just give a brief background about this portal. So when COVID came, okay, so at the ministry level, health ministry, there was no such online platform was available. Okay, because everything was locked down. All training, all medical college, like training institutions where health professionals or frontline workers, especially the, which are doing job in like policeman and traffic and and so many frontline workers. So for their training, there was no platform was available, and all the training institutions were locked down. So ministry has called a meeting, and at that time I was the nodal officer for the CHI, Center for Health Informatics. So I was well versed about these technologies, digital health initiatives. So I was called and at that time, ministry has developed around 120 or 150 modules, online modules in the form of PDF to sensitize the people, frontline workers about the COVID, how to prevent the COVID, how the uh, frontline workers, what are the precautions should be there for the children, for the pregnant women. So there were so many modules were developed, and these modules were hosted on iGot portal. There was a Diksha portal in 2020, and in Diksha portal, the Ministry of Education's portal. Even the Health Ministry doesn't have that portal or platform where these modules should be, we can host. Okay, so that was, and after that, Ministry given the responsibility to NHFW. So kindly prepare, send a proposal to develop their own portal platform. Okay, so in that way we have developed this proposal and everything and sent to the ministry, and ministry had decided to give the fund and everything to the NHFW to develop it. So I have been involved in that from the writing the proposal to the ministry and giving the name as well, because the name was also there. Because generally LMS is set learning management system, any learning management system online, but it is a LMIS, learning management information system, right? It means it is also the learning as well as information. So in this way, this portal came into the picture. So the basic purpose, so because in government setup we have, if something is created, so objective or its scope has been expanded as per the requirement. So ministry has earlier the purpose of developing this portal was to host that particular modules from iGot to this section portal. But now its scope has been changed or broadened. The first scope is online learning. That ministry has said that it will be used for the online learning, that the medical students, or it can be used for the continued medical education, online medical education. So this portal will be used for the learning purpose. The second objective was online training, because suppose we want to conduct an online training or any training for the health professionals who are working in the remote PHC or health wellness center of Northeast. Okay, so the first thing is there is a lack of health professionals in that area, and the second thing is we have to invite them and confirm the training. So the best thing is we can conduct online training for those professionals. So this portal is also used for the online training of health professionals. And third thing is ministry has their own portal that is called TMIS, Training Management Information System, through which all the around 20 states they are using TMIS for recording the data of their trained manpower. So those health related trainings which are going in the states in the physical mode, because the physical trainings are also going on, and the state coordinators they will feed the data of their trainings on this TMIS. But we are totally dependent on the states. So ministry decided that why you are not integrating that TMIS portal with this section, so that for the online as well as offline trainings, both type of trained manpower data should be in the ministry, so that at the time of emergency we can use that particular data or trained manpower in the country. Okay, so this is the brief, three objective of this section platform. So section has been developed with the open source model, because many people are from the technical background, so I will not go into much detail because this is a very popular open source, software model platform, and it can be customized as per the future requirement. Suppose you have a special requirement for your training purpose, so we can customize it. Okay, and it has a review process. What the content is uploaded on the portal, that is peer review, just like any journal, research article or editorial board. So it can be reviewed by the experts, and after the given review process, it can be uploaded. Then the Saksham mobile application is also has been developed with the NHFW. So currently it is available in the Android Play Store. You can download it, because for the wider use of this portal. So multilingual courses, and it is two-way user access, because some courses are there which are open to everyone, like any general public can access these courses, but some courses are also, or training modules are access to only the authorized professionals, because we are also using this portal for the training purpose. So this training component is not open to everyone, it is customized. Okay, so general public, medical students, healthcare professionals, and frontline health workers. So these are our target groups. So in the 2023, ministry has showcased the Saksham platform in the all health working group meetings of G20, and the last year under the Quad Presidency of India, the Health Ministry has showcased this platform, and they have offered it as a digital public good to the Indo-Pacific countries. Okay, so we got request from the Myanmar for giving this particular use of this particular platform, Saksham platform, and there was some island country, so I will not give the name. So we have got two foreign requests through the Ministry of External Affairs for application of this portal. So this was a platform, overview of a platform. So our colleague Dr. Manu Saini is with us. So we have other initiative of the Health Ministry, that is National Medical College Network. So this is a network of 100 medical colleges who are given the responsibility of development of the medical courses. Accordingly, they are doing so.
Can I have the laptop here so that I can show the photo?
आप मैं वहाँ बैठ जाता बताइए
No, then I'll.
पोर्टल में जो ऑनलाइन है उसको.
Can you give me the laptop here so that I can?
यहाँ से लो.
चलिए आप पहले मेरा PPT प्लीज खोलिए. Yeah, very good afternoon, all of you. Thank you, Dr. Yadav. You have already set the platform. So I am here on behalf of Dr. Amar. So before giving you a walkthrough to the Saksham platform, I want to give you a brief introduction about this National Medical College Network. So Ministry of Health and Family Welfare, they have launched a National Learning Management and Information System for the better health education quality of health workers on the Saksham LMIS portal. And AIMS New Delhi was designated as a National Resource Center in the year 2022. And we have been assigned the task of populating the content for medical education on Saksham. So as NRC, our prime role is to coordinate with all the stakeholders, that is NOHFW, our RRC, all the medical colleges linked in this network, NIHFW, and the Empire School of Health. So the vision of the government was to supplement medical education imparted to all medical colleges of India to provide medical education at the national level through a centralized platform, and to provide best access to best quality medical courses across geographic and social backgrounds. And the objective was also to serve as a digital capacity building tool for medical professionals for both pre-service and in-service, and to provide a platform for facilitating collaboration and knowledge sharing among educators, students, and other stakeholders, and also to streamline the administrative tasks to improve operational efficiency of educational institutions in delivering and managing the courses. So in the current NMC network, it has one RRC, that is AIMS New Delhi, and we have 8 regional resource centers. And from in last 1 year, we have expanded this network from 50 medical colleges to 150 medical colleges. So like with AIMS NRC, 21 medical colleges are linked. With RRC, SGPJ, Lucknow, they have 39 medical colleges connected to them, and so on. So now let's have a look at the Saksham portal and the NMC and content of the Saksham portal. So why we have created this, why the thought of populating the content on the portal came. So it was to fill in the dearth of quality medical faculty by developing e-content by leading teachers of our country, and to cater to the changing learning platforms of the new age students. And this platform, it holds medical undergraduate courses like from anatomy, biochemistry, pathology, pharmacology, and so on. And also there are skill modules aligned with the NMC curriculum. And the content is also vertically aligned by diseases like coronary artery disease, bronchial asthma, and so on. And the portal, it is interspersed with educative and informative questions. And there is also an asynchronous discussion forum is there, and we have an option of user feedback. The students or the user, they can give their feedback about the courses, about the portal on that. So currently we have 467 lessons have been uploaded on the Saksham portal by the NMC, and this is a screenshot of the medical e-learning content that have been uploaded on the Saksham portal. Can you please open the portal? Yeah. So this is our portal. The medical content here in the portal, it has been, cataloged into two categories. One is, can you please scroll up the screen? One is undergraduate courses e-modules and the one is skills and simulation based e-modules. Can you please open this undergraduate courses e-module? Yeah. So in this undergraduate courses e-modules, it has been further categorized into preclinical, clinical and paraclinical categories. And the skills and simulation based modules we have categorized into beginner, advanced and expert. And also we have one more category like integrated courses. Integrated means the different faculty of different expertise, they create a course with the name of integrated courses. So, and in this, to make the lectures more engaging, more interacting for the students, you can create the you can intersperse your lectures with the videos, with the live videos. You can make animation, you can make graphics, and we have a team of graphic animators at AIMS New Delhi. They can help you with that. Can you please scroll on and open the medicine course? Dr. Yadav, can you please help them to open Dr. Ambud's course of CAT?
Medicine.
So, yeah, medicine and CAT, so that I can show them the animation, that how we prepare animation for the courses. So these are the various types of courses, and courses here, they are in the video form, followed by assessment. The student, after learning the course, they have to go to the assessment, they have to complete the assessment, then there the discussion forum is there. In case you have any questions you want to ask to the concerned faculty, you can just drop in your question there. The faculty will get a notification on their Gmail and then they can answer your queries. And after that, at the end of the lecture, there's a feedback forum. So you can give your feedback regarding the particular course, regarding the overall experience of the portal over there. Sorry, in the search option, you can just type and you can find CAD. Yeah, this one, please, first one. So like this, we have video, then assessment, and after the assessment, so this is one. First, please continue. Lesson one, the introduction part. I just want to show the animation. So these type of videos, lecture are there in the portal and under the attention categories. And you can make your lecture interactive by putting on an animation like this. This is an animation representing the heart attack. And this animation, it has been created by our animation team at AIMS New Delhi. So you can make your lectures as much as interactive you want. You can intersperse them with your live videos of your procedures and everything. So can you please go back to my go to the skills section? Sir, एक skills का भी दिखा देते हैं. From there, explore courses you can go. Sir, कोई भी. So in the skills part, the lessons like the lectures are in the form of a video, as well as we have a SOP document regarding the procedure, and a short demonstration of the procedure is also there. And the rest of the part like assessment, feedback is same as we have in the undergraduate e-modules. Please चला दीजिए थोड़ा सा so that we can have a. So in skills module, the faculty, they record their live demonstrations, and then we make the strong package of the videos and the SOP, and then we upload them on the Saksham portal. So please, sir, वो PPT में मेरा पास आप करा दें. And to log in to this portal, you just need to register yourself. You have to put in your medical ID card, and you can have the access to all these courses. And these courses are free of cost. You need not to pay anything, and these are self-paced. Like if you don't want to watch the whole video at one time, you can stop your video and come back. You can watch your lecture the moment you stop, or you need not to start from the scratch. So please. So as NRC, we work with the vendor and the NIHFW team for the development of a user-friendly LMIS. Quality peer-reviewed medical content by leading teachers was uploaded. We have formulated the SOP and guidelines for creating the content. And standardization of templates for content upload on the LMIS was done. We developed a review process system on the Saksham portal. And in coordination with the NIHFW team, we have stabilized this portal, and a dedicated studio for this video shooting and the content development has been set up at AIMS New Delhi. So this is our SOP, and like this is our workflow. Like if you want to contribute to the this portal, so you need to select a topic as per your NMC curriculum. You need to mention the NMC curriculum of the particular topic. Then you send those topics you are interested in to us for approval. Like we'll check whether we have not assigned those topics to someone else. After that, you just need to prepare the PPT on the approved topics, and you have to peer review your content by one subject expert of your department or any other government medical college. You can get it done, and then you need to send the PPTs to AIMS New Delhi for further formatting as per our NNCN format. Then we'll get it formatted, we'll send back to you, and you are go ahead with the recording part. Then after you do your recording, you send back us your video recorded lecture. We'll get it formatted in the as per the NNC format, and then we will send you the final recorded videos for your final approval. That you go through the video. If you want anything changed or you think that some part has omitted while doing the formatted, we'll get it corrected for you, and then it's okay, it's ready to go to upload on the LMIS portal. And just before the upload, we'll need a small information about you, like regarding your institute, your affiliation, and some information about your reviewer, and 5 MCQs to be uploaded on the portal. And like this is the SOPs we have prepared. Like you have to prepare the PPT on the NRC approved topic, and in that we have a template of the PPT we can share among you all. Anyone can contribute to this, and in that it is mandatory that you need to mention the learning objective as per your topic, as per your NMC competency. And the important thing here is that you have to check for the plagiarism or the copyright issue of the images you are using. And if you feel that and you are not sure that whether the image you are using is having any copyright issue, you just simply need to send us the images. We'll get it redrawn, and I will share to you. You can use the image, and then you have to mention the sources or the references you have used in your PPT, your material and the content. And we prefer that you record in a very soundproof studio so that noise is not there. And we advise to record, your best is to record in a studio setup. And the limit of the slides or the final video should not exceed 18 minutes, because at times it becomes difficult to upload or buffer while you watch on the portal. So to minimize that hassles, we recommend to make the final video of maximum of 18 to 20 minutes. And the PPT, it should must have a designation and affiliation of both the reviewer and the author. And you can make your PPTs engaging by using pictures, animations, videos. Even you can use pen tabs if you want while recording your lectures. And the review by one subject matter expert is a must. So thank you. In the end, I would request you all to please contribute to this national endeavor. And Dr. Yadav has our contact information. If any one of you interested, you can send us the mail. We'll share all the details, all the SOPs. We can share the curriculum to you. We can share the PPT templates. You can just prepare your PPTs and send us to us.
Madam, I have a request. we are anyways collaborating with one super specialty medical college 8 states of Northeast.
Yes, sir.
Please hold one separate training session for our master trainers.
Okay.
And then
we can discuss with Dr.
Yes,
Yadav
yes,
and we can
definitely,
plan, sir.
definitely.
We can plan. No issue.
We can then in that case, we can have more because you'll have much larger data sets from
Yes.
across the country.
So thank you,
Oh, thank you,
Madhu,
sir.
and we have just want to add because the current vision of ministry is to make it this Saksham and platform as a dedicated platform for the online uh, learning of all the MBBS curriculum, so that any MBBS student they can, if they want to some additional knowledge, they can use this. So we are in the process of developing the content from the subject matter experts across the India. So we request all the experts from Northeast if they can contribute, so it will be great help for the ministry as well as society. So we will definitely contact you, sir, and for the specific requirement. And the ministry can do anything for the curriculum development for this MBBS.
Another thing what we must take care of is that I had attended a session in Delhi. Sunil sir, in one of the CME classes, what I found that there were doctors from Manipur that were there, but the subject was from Kerala. His English was not being understood by a lot of students over there. So poor students they could not muster courage to doctors speak. They're just taking photographs in the CMA session. Once we are doing this, we also must have a platform to convert into regional languages of Northeast.
Yes, sir, we are.
It's very important. But the English will be very limited. Sir will example, when I go to hospitals, like you go to PGI Chandigarh, in a clinical session, if I have to record something, there most doctors are from South India. Patients speak Punjabi. Now, there are special translators to handle that. When doctors from Manipur come to Delhi, there are translators who help them to speak the problems to patients. So we should have something AI interface.
Yeah, definitely, sir. We need.
It will be a next level of application in this. Saksham will be much more effective if we are able to convert the content, at least if not all the text or voiceover, we are much more effective in learning and the translation.
Definitely, sir. We need the help from Amazon and other your stakeholders to make it more strong. This portal in terms of public health as well as medical courses, or technical requirement, or technical enrichment as well as content-wise enrichment. So we are looking help from you guys. Thank you. Thank you so much. There was kindness. Yes.
The content has to be designed only in English, or is there any way like it can be recorded in the regional language? Because that would be a boon for the people in Northeast.
Yeah, definitely.
There is an AI app called Bhashini. It's converted into some limited languages. What we have talked about, we are talking to the Ministry of IT, that give us AI lab, where we have partners from in fact, Manipur is supposed to be language. It's not Manipuri language, but might be different language. You have Garo Hill, Khasi Hill, Gansi Hill, Galo, Adi, Nishi. So not is not holistic. So we need to have all those AI tools running. Where we because that is when we take it to the last line. Doctors will be understanding this, but you're right.
No, initially then start with English, and after that we will convert it as per the user's requirement or.
What the portal actually shows us is that it will be recorded by the subject expert.
Yes.
So when the subject expert is telling in the regional language, is recording it in the regional language.
Yes.
There is no way that we need to convert it to any other language.
No, not yet, but it can be done.
What we can do, sir, in the Puranic, sir, the proposal on PM Divine, where we have talked about one design studio in each medical college in Northeast, with other Guwahati and so forth, there and counter hub in NHW. We have to redesign it, where a doctor, let's say, will speak in Assamese, but then our tool converts into a language voiceover automatically.
What I meant to ask is, suppose he's recording it in Assamese, so that when a student from Assam, he has not understood the lecture maybe in the class,
he can access the tool and he can get an overview in his own language.
Yeah, no, just like in Netflix or other way, na, where you can convert your language. Suppose it is English, but you can convert it in Hindi as well. So in the same manner, it's a technology, sir. But we need both kind of format in English as well as regional languages for that.
I think we can utilize telemedicine. Like we on our at my studio, I get in log into your the structure account and whatever and actually whatever.
Like live classes, we also have, sir, that
Yeah, live and recorded also.
recorded both,
So
both, sir.
we can come out with the weekly program or monthly
Yes,
program and whoever is keen.
They can join.
The teacher, the today's time teacher role is also with the, everything is available on ChatGPT, everything is available on Google and YouTube. What extra you are contributing? You should be really working on those critical thinking, innovation, where there is a complex exercise required there only. Otherwise, nobody loves PowerPoint lecturing, and today's children are, they absorb very fast. Their speed is much higher.
One of my friends is teaching in one of the medical, I can't name him.
Yeah.
So after his lecture, a student sent him a text. Teach, don't preach. So basically, they have seen everything on YouTube.
So, no. The
And
thing
they pass
is
it on
that
also like that.
we have the content. It is not being utilized and not reaching to the real targeting. So we have to come out with some innovative ideas.
Yes,
I think
definitely,
we must be utilizing, like if I work in the hub and scope in the
Definitely, sir. We will, because the joint,
we should be promoting and we should be airing.
Sure. The first thing is to make the portal in that friendly or student friendly, and second thing is content as per the requirement, so that they will go to the portal.
Liberty should be there to be so that we can communicate in any language and it isn't absorbing more.
Okay, sir. Thank you. Yeah.
Certain component of this instruction portal, especially TMIS, is duplicated with the instruction portal.
Yeah, you can say that, but earlier it was the TMIS, but we are also integrating the instruction portal in section, because the current ministry is saying that no, there should be no different portals should be there. So just integrate all those portals with the one. Yeah, we are integrating it.
Thank you.
Okay, so thank you, and we request all of you kindly contribute, and this is a small video about the Saksham platform.
The Learning Management Information System is a step forward in India's digital learning revolution, undertaken by the Ministry of Health and Family Welfare under the Government of India. This digital learning initiative has been developed by the National Institute of Health and Family Welfare. Saksham provides a dedicated online platform for public health training and medical education initiatives, which can be accessed by medical professionals across the country. This learning management platform is created with the objective of providing a common and accessible gateway to quality-driven and up-to-date courses. Saksham intends to prepare a central repository of teaching and training materials, while maintaining a central database of trained healthcare professionals undergoing training in India. Further, by integrating Saksham with a Training Management Information System, or TMIS, we finally have a unified platform to monitor all offline trainings in the country. The ministry has undertaken the development of Saksham with a mission to provide healthcare staff everywhere with a standardized training format. Think about this. How else does a medical professional in rural India access the same teachings that are accessible to healthcare staff in an urban setting? In its current version, Saksham offers the ability to search the database course-wise, as well as based on individual enrollment. Learners will get a certificate after passing the course and assessment. And this web-based portal can be expanded to include a mobile app. Currently, Saksham is hosting over 300 public health related courses offered by various program divisions of the Ministry of Health and Family Welfare. Clinical courses offered by National Medical College Network or NMCN for medical education are also hosted on Saksham, and several courses offered by NACO in collaboration with Johns Hopkins University are also hosted on the same portal. With the advent of new technology and the ever-growing requirement of digital learning, Saksham plays an important role in ensuring quality and standardized teaching and trainings to all health professionals of our country.
Thank you. Thank you so much.
Thank you so much, Dr. Saini and Dr. Dharmendra Yadav. Such an insightful session. We really need these amazing platforms for our futuristic youth. Now, I really want to request Anand sir and Dr. Loro sir to facilitate Dr. Saini and Dr. D.K. Yadav.
Although, sir, you had started this file, and we and NIS met because of your letter. It got delayed only because of code of conduct, otherwise we could have started much earlier.
Sure, sure, sir. Anytime, anytime.
Thank you so much, everyone. Now, we will take a short tea break. So, let's gather in 15-20 minutes back. Now, we will delve into the concept of digital twins and their role in tertiary care hospital management. I invite Dr. Prabjot Singh Suga, Associate Professor, School of Planning and Architecture, New Delhi, along with Sri Anand from Amtron to share their insights.
Purani sir, this requires your attention, and Madam Chakravarti, this requires your attention. So when we build hospitals, currently the whole focus of our planning department is on civil construction. You make a building, but when a patient enters a building, or as a medical superintendent, as a director, when you have to maintain the building, every day your table is piled up with thousands of files. I see in your office every day. And even when he's talking to me, he's signing something. So is it true digitization, yes or not? So if we spend 700 crores rupees in a hospital, why can't we spend another 5% additional budget and make a building smart? I have seen new parliament also. I have seen your office also, AIMS Guwahati also. I have seen donor head office also, NAC building also. I don't think internet works anywhere. I don't think so that anybody knows in front of him when somebody comes for a payment of file, whether somebody is trying to clear a bill when warranty is still valid or not. I have cases in ESIC where, unfortunately, because how will MS know whether AMC was valid or not? AMC was valid, still those people are passing bills for repair and maintenance. And that's a huge cost. And the second topic is that there's a lot of unease in accessing healthcare within the hospital. When a person comes from a remote area to hospital, especially in tertiary care, he doesn't know where to go. Signages are not good. After finding the OPD with great difficulty, then he doesn't know where to go for biochemistry, where to go for radiology. He is wasting a lot of time just moving around finding a service within the hospital. This is a platform. I traveled to France, Dassault. I went to Dassault headquarters, and I went to a lot of hospitals in France. They have adopted this wonderful technology of digital twin, where you can virtualize everything in a building design, right from designing, maintenance, to tomorrow there's expansion. Everything is totally on board. So when I came back, anyways, I'm assimilatedly about. I met Dr. Suga in School of Planning and Architecture, who said, sir, you must incorporate, because SPA, we don't know it, but it's a only university under Ministry of Urban Development. They write the manuals for CPWD. Unfortunately, when any central institution wants to do something, your hands are tied by CPWD, in states by PWD. So we need to change the manual. I'm working on that with Ministry of Urban Development, that, give the liberty. Today we are in a time where, digital twin should be a reality. So when you make a SOR should have provision for digital twin of the building itself. Otherwise, buildings are not smart to access for patients anywhere. Sugaji, you can just take over. I just can you run the presentation?
Good evening, everyone. So I'm Prabjot Singh from Westfield, Delhi.
Next slide. That was Dubai agreement? No, sir. This is not Dubai, sir. This is France. Galerie. Okay. Of about 30 minutes from Paris.
Okay. So, okay, I think let's stop for a moment here. So the thing is, if you go back in middle times, there was the idea of a master builder who had knowledge of designing, construction, sculpturing, everything together. Then he had a team in India, we called it Stapati, was mainly doing temples. So, but as we evolved over the time, as the industrial revolution came and a lot of things happened, knowledge expanded and the fields got diversified and the specializations came in. It's when, you started having these different cells of their own, like the engineers are designing the structural part of it, the consultants are doing HVAC and so forth. And now it has become more complex with the energy studies coming in and intelligent businesses coming in and all that. But
the problem that came alongside it is the number of stakeholders that go into a building industry. Let me give an example. Right from designing stage, it's the architect and the consultants. Then on the ground, it's a contractor and his team. And then the skill set is so varied from the person who's educated in a university and with all their drawings and everything to the point where the guy who's only knows how to lay a brick. This whole varied path has to be covered, and a lot of things cannot be internalized. As a result, whatever you do, whatever the vision is, at the end of it, you will probably be able to achieve only 60-70% of it, or maybe even less. Okay, but thankfully at this point, when the technology has come in, it is trying to create this sense of collaboration between different stakeholders, and trying to create a system by which you can create some kind of a twin or kind of a virtual system in a building, which with all its system and function can be tested for its performance and for different alternatives before even it is built. Building industry by default had this problem of not having a standardized means of production, because every building is different. It's a bespoke. It's basically you customize every building. So it has never happened in the history that you actually had mass produced a building. It's not possible. There may be some ways of creating certain systems, certain elements, but a building by itself cannot be mass produced. So as a result, while other fields have gone into the mass production in industrialization and all that, so this industry has never happened. But thankfully, at this point of the time, we have technology that can bring all these things together. And then it can give you a better control over the quality and its execution and its maintenance and everything. So you look at the chart on the left and you can see the cycle of the building, from right from the point it starts, on the paper to its detailed design, analysis, documentation, fabrication, construction, and eventually its operation and maintenance, and if not demolition, then renovation and so forth. So this has to be internalized. Now even that last part has to be internalized. You have to take into account what you're going to do with the building once it's demolished. That's also part of it. So, yes. So 3D digital twin, which the Solid is offering, and I think a couple of other platforms are also offering, is actually basically a thing which is more than 3D. In the sense you create a virtual twin, but then it is supplemented by all the information that is there as far as systems are concerned. For example, you can also put in the lights, you can put in the other services, the HVAC, the piping, the wiring, and it will mimic its performance virtually and tell you how the building is going to perform. That's happening. That's already happening, and that basically bridges the gap between what you envision as a building, as a visual product, as well as a performance system. So this is actually an example done by Dassault.
It's very simple. When you make a building, madam, you will find that after construction is over, you will find some leftover TMT bars, some leftover cement bags, some leftover bricks. And the engineer is very happy for some additional, they have some local purchase kind of a thing. This puts an end to everything. When I design a building, it auto calculates everything. If you say that this much tonnage of steel is required, it will tell you dimensions of steel. If I know my foundation, it will tell you what is the strength of rebars which is required. How many exactly in numbers, what shape, size, everything. Wastage is reduced. Secondly, before a building is made, you can visualize everything after this, how it looks like. In a hospital, you have pipelines. You make a drawing, then you put a pipeline through a beam. Then it will get a dent barrier. Then you have to then take it around. You have to then drill holes. Those things are think of past industrial.
So right now we have a system of BIMs which is called Building Information Management System. Right now we are following that in the industry in India at least, that you model the visualize a building and you actually put in the services as they would be in the real life, but that still is not bridging the gap. This I think is a leap forward. Let me give you an example of this auditorium. If you want to design this auditorium with the, let's say, without any conflict. So this software or this kind of platform or similar platform will actually tell you that this is how the conduit is going to run for electricity. This is how you're going to place your air conditioning for the maximum benefit or the maximum efficiency, and even the flooring and the structure below it. And if there's a slab, how much RCC and what level of bending and bar and everything that can be calculated, so that there is no wastage, there is no conflict. And when it comes to execution, you have a seamless, kind of, you can say, execution of different processes. So and I think this is an example from the.
And another advantage, sir, like what is happening in AIMS OPD. If I had a 3D twin out there, system would have told me that if I want uniform coverage of internet in the building, what should be the design of antennas? If my load of persons, what's my peak load? Not today, even 5 years from now. System can be designed. What happens is make a building, then everywhere you'll find that wires hanging, you're again breaking walls, putting new wires, loop line, things like that. It's a mess. Building maintenance is a mess. This streamlines everything and you don't require any input from your engineer. And you can keep full check on your procurement. All leakages can be stopped because you know exactly what is the life cycle of everything. And if it is not there, you can hold the OEM to task.
I think I just want to add to that, like when you're designing the building, this, or let's say, not even the building, even you can look at the cityscape or larger level, you can actually create scenarios. Like in this case, as Anandji told, that if you want to visualize your, let's say, OPD department of range, for a footfall of, let's say, 1,000 patients per day or 2,000 patients per day, what would be the, the area, or what could be the, let's say, the kind of layout that you want. So it can stimulate that for you right in the beginning. And if you think that, it requires a future expansion and there should be a space left for that, it can also do that. So I think those kind of scenarios can definitely be, created, and it can give you a more, you can say, a lot of iterations and let you choose from the, most probable one that can be feasible and buildable in the future.
This is the use case of China, sir, where they built in open stadium, COVID hospital. You require immediate decision on a lot of things. You just tell how many patients, how many isolation wards. System auto does everything. Moment you give the landscape, even if there is a landscaping, it's not a flat land. It will tell you how much cut and fill. Now, what should be the separation distance? If there are norms to separating patients, everything can be designed and done in hours compared to days. And here, what is happening, every time you do construction or different consultant will give you different kind of reports. Here we can standardize things in one go.
In this particular hospital, there was one very interesting thing that it was that they had to build it very fast. So they actually took the parameter of the material size available in the market. For example, in this case, the panel size that is available in the market. So they worked around it to create the hospital. That reduced the waste and that made the construction process much faster.
This thing, sir. So you were telling me that you have this hunch that what the power department is charging you, you are consuming less, but they're overbilling you. The system gives you total control, total building, blocks, sub blocks, everything. In fact, you can have carbon footprint ready. What's your daily carbon emission in the building? You can know that. If you install something which is called energy efficient rating, how much it went down. Everything in real time. Secondly, if there's a gas leak, it'll tell you automatically, depending on the wind direction that day, which way the leak will go. If there's a fire, because the fire is that I'm working on a model for Vaishno Devi. Every year in summer, there's a fire. And from the foothills to the Bhavan, it goes very fast. Till now, they have not been able to how to manage it. We are now creating a digital twin of entire Vaishno Devi. That is, the fire will tell exactly by the watch, in every minute, how the fire will progress, where to dig a trench, where to put water, so that we can control it. This gives an amazing level of control on building automation, management, and disaster management. All into one. One thing I can show you, we are working with the World Bank to map the Brahmaputra Valley. Every year floods, everybody loves a flood. In Northeast, everybody loves a flood because it benefits a lot of people.
But if you spend 5% of that, then you can not only control flood but also generate so much of electricity that this is taken care of by everything. This is a simulation of gas, sir. In case of a leak, if I have to evacuate, how it will happen? You can't do firefighting at the last moment. This tells you everything. You don't need to go inside the building. From where to evacuate, how to evacuate, everything is there totally automatic.
Next. So these are the different systems that are there, and these are actually giving you the performance. They are not just for the, for you to calculate the space required for it while you're making the design, but actually they will be fitted with the sensors and all the, and their performance can be virtually calculated before even the building is constructed. The beauty of the system is that, the problem that we tell you, the thing is that once you make a building, there's no way you can calculate it against anything else for its efficiency. It's like a human being. It's like, as your doctors say, there's something very specific to the body. There's some general things. So for a building, same way, you cannot calculate its performance. I mean, how would you calculate a performance of this building against whom? This is perhaps the only nearest possible, you can say, system where you can actually create different scenarios to say, okay, this is more efficient than the last one. We are doing energy efficiency calculations nowadays also, but then I think those systems are disconnected from the design and other processes. Those are things which happen in the last because they are requirement by certain agencies that you want to show the building as efficient, more efficient, so forth. Yeah, that's okay. So so eventually, basically, it will definitely help you, in management of your building. So the building information management systems, like while you're running the building operations and all that, will definitely help you in streamlining different parts of it. And also, as we discussed before, in the end, that if you want to do away with the building and all that, it will also let you, give you the options that how the building can be given back to earth, so making it completely sustainable and efficient during the operations and during the construction. Thank you so much. Thanks.
I think you have to be in touch with sir and madam, and we can do a lot of things in some of the buildings initially to show what are the result means.
Definitely.
We just about smart building and conceptual theory, something to do with the environment. Taking into that.
See,
it goes much beyond that.
Smart building and Greha, okay, let me add this. So, sir, see, the smart building Greha, they are called green ratings. They started with the US DGC. They started actually in the United States in 2004 or 5. So the idea was to basically rate the building for the performance in the sense that you will take a lot of parameters into account. So Greha is an adaptation of that for the Indian context and taking different advantages, and they give the ratings and all. The thing is that there are loopholes in that, but this system actually is giving you scenarios before it is being built.
I will add something, sir. When you talk about a green rating, what the new purchase norm worldwide is going to be, when we calculate the cost of a product, it will be cost of product plus the cost of carbon footprint. So you have to offset that. You will already start the business. So when I buy this in option, I buy 20 things. Now, claim portal will have to do a calculation after 5 years from now, where it will tell, okay, this is the pricing in Guwahati and the pricing in Delhi. If it is 15% offset more, then I'll still go and buy from there, not from them. You have to go for re-rating of building. That we will not tell you. We'll tell you exactly. Tomorrow I want to reduce my carbon footprint in construction by 20%. My system will tell me that how much of my plastic chair will be replaced by cane and bamboo, and your chicks, plastic chicks by bamboo chicks, actually blinds by bamboo chicks, so that my carbon footprint of procurement and the building construction will go to us. That we have not. It's a standard thing. It's not a living thing. This is a living thing.
See, one of the very big problems with the rating systems, and it's a big problem, is that a lot of rating systems in the world are actually focusing on the operational energy of the building. Okay, that is how the building run every day with the lights, AC, and everything. The big component is the embodied energy, which is that energy that goes into making the building. Nobody's focusing on that. Nobody's focusing on that.
We see the airports are like that. All airports are being constructed
in the line, so they will get they have a good operational energy. They will put a lot of solar farms and all that to make it,
And also glass screens are used.
If you ask glass people, they say the glass is green. Use of light is, yes, definitely. I'm saying, I mean, you can work. So everything is mostly about operational energy. It's not about the embodied energy. If you look at all the ratings, every system is talking about the operations. Because talking about embodied energy is difficult. How much of carbon you've eaten away while making this building? Nobody talks about that. We're talking about the fact how much of carbon you're using while planning this building. Yeah, it takes into account somewhat embodied energy because the data were, one of the reasons also was there that the data for embodied energy for the products was not also available, was not widely worked out. But now I think we're getting to the point where that can be integrated into systems. Thank you.
So we have an event in Paris in April after the March. I would like to invite. I have able to invite 8 or 10 people. I'll show you the city of Paris, how they manage construction and disaster. If it rains for more than 5 minutes, in every street, how much water will accumulate? Beyond the limit, how many houses on ground floor will get submerged? Everything is documented, and that is linked to your disaster measure, ambulance services, police, everything. You start evacuating people faster. Barak Valley has flood issue. They should have flood issue. We have a different issue. We love flood for different reasons. But this can solve the problem. Every people are displaced. You're losing water. And somebody don't have water to drink in Northeast. So how do you address that?
Just study of whole Hollywood is on. Whole Malibu town in Inferno and
because with climate change, impact will come. I met a research scientist in Switzerland. He has gone on different levels using this platform. He is recording sounds of animals deep inside Amazon jungles. And if the variations of sound are reducing, it means that some flora, some fauna is dying. Some animal species are being lost, which are never discovered. So this technology is being used on a much larger scale. I have proposed a document to the Ministry of Earth Sciences. Let me map all the coastal lines. We'll tell you what's the impact of climate change before it happens. Because today, data is a science. If you are well planned, because there has to be a method in madness. Guwahati is not planned. Sir has so many patients. Tomorrow, if I have to double the patient load, your security will not be able to tell you. This will tell you that if I see my OPD, then I can make it smart. My system will tell me that in May, if I have done 1 lakh OPD, how many was cancer, how many was ocular, how many was cases of pulmo. And it will give me a graph that you increase the intake of more doctors because you have more pulmo cases. We are randomly employing doctors, not by data science. This tells you everything because the job of MS and a director is thankless job. You do a lot of thankless things all day. And that will be taken over by them. When a doctor can actually focus on what he needs to do, research, better treatment, things. Ravi, can we have the next session? Well, yeah. Next slide.
Okay, so now we have Gaurav Seni, AVP EMT. He specializes in 5G technology, including implementation and have potential in wireless 5G solution and AI solution. Sir, please.
Gaurav ji, my introduction to market. So Gaurav ji is a very talented telecom engineer. He's been working with us through the 5G labs of Northeast India tablet. So we all hear 5G, 5G, 5G. Beyond video, what it is, what people don't even know. The 4G is not a fashionable thing that your iPhone changes 13, 14, 15, 16. You should understand that 5G enables more and more services to be delivered, more applications delivered, which 4G will not do because of latency issues. Now, when we access a video from Guwahati, there's something goes around buffering. We should understand what is latency because your servers are in Delhi, Bombay. Your Netflix, when you load a movie, sometimes buffers a lot because your main servers are in some other city. And if you have 1 lakh customers, every time it downloads, we go to the Bombay server. That causes a lot of heat also. In fact, your data centers are creating a lot of emissions. 5G technology and CDM combined will change the scenario where EV gives inside storage, easy access, and low energy consumption. And that's what he's working with me now.
Thanks, Anandji. So we, like Anandji said, we hear a lot about 5G. Let me touch base briefly about differentiation between 4G and now what's 5G. From a consumer perspective, it's all about data. From 4G, we had some limitation in the data throughputs, and in 5G, that has been extended. Up in each handset, we can get up to 100 Mbps practically. Theoretically, we can talk about 1 Gbps. 4G was limited up to 20, 30, 40 Mbps. So data throughputs per user is increased, but that's from a user perspective. When 5G came in, it brought in a lot of use cases. Technically, there are three use cases were there: EMBB, which was broadband, then IoT, which was more like thousands and thousands of IoT devices can be connected over 5G networks, and there was URLLC, ultra low latency. So latency is something the delay between a packet from one end to other end. Now, when 5G was started, this latency thing was considerably improved, and that improved consumer experience and enabled various use cases. We'll talk about more in terms of how it helps in healthcare. Next slide. So, if we talk about healthcare, there are a lot of challenges we see today. Coverage is one part of it, where all the healthcare facilities, if I talk about hospitals, the coverage may not be ample there. Even the public carriers, they may not have a proper coverage. Communicating between the doctors, the faculties, and other people there is very hard. That could be one part. And a lot of institutes are in remote places in India. That coverage plays a key role. Then we talk about other data. Today, if we talk about MRI, PET scan reports in the digital form, they could be 1 GB each. So all the data reports and everything is getting bigger and bigger. We need to have a system which allows higher throughput or higher speeds to enable those large files to be transmitted. Even internally, I'm not just talking about over internet, but even within hospital, from one system to another, that needs to be ultra fast. In terms of IoT, so when we talk about healthcare, currently the healthcare ecosystem has been deployed, has been deployed with a lot of IoT ecosystems, a healthcare IoT systems, but they are mostly in terms of either connected on wireline or some Wi-Fi system, which is not reliable. There are various studies which talk about why Wi-Fi or wireline system is not right. Dr. Suga here talked about the healthcare ecosystem, just the platform. But currently, a lot of healthcare systems are old buildings where there is no wiring or systems deployed which enables this IoT systems to be seamlessly connected. That's where this wireless technology of private 5G helps.
IoT, sir, is very important.
Especially running any hospital with IPD. You know, in every IPD, you must have a lot of beds, and there's a matron, and there are a lot of sheets in one ward. You assign 20, 30 beds to a patient. I'll give you one example where there's a lot of manual things how IoT will change, and I can demonstrate it in real time in any of the labs anytime. We have a ready-made solution. Let's say there's a one station IPD section, and there are 40 beds, and there's one nursing station, and you give drips to people. Currently, what is happening? When every consultant doctor or physician or surgeon will come, he'll prescribe the flow rate. There's a chart in the bed attached to the bed, and the nurse will come, she will physically adjust the drip rates. So that drip is given according to the prescription given by doctor. And then in many times, especially in old people, cannula gets blocked. And hands get damaged, veins get damaged. It's everything in a hospital. Everything is manual. And we should also look at life of a nurse more humanly. She's doing a lot of work, already stressed, day and night. She's overstressed. That's where IoT gives a change, and I can demonstrate real time. So we have developed a sensor attached to any normal drip. Through a Wi-Fi, we give a tablet to a nurse. That 40 beds don't go to the bed at all. From your tablet, you can control the flow rates, set the flow rates in all the drip sections. And in case there's a blockage, on her tablet, she'll get an alert that this bed is a blockage. Before the damage is done, you go over that. That's a real change, how it will bring change in the hospital. I'm not talking about, it's not a Star Trek movie. It is something which you can demonstrate. I put this in Senapati Hospital. I put this even in IGM in Nagaratala. You can go and see over there. I put in Gyalsing also. It is something so easy. We have to use IoT devices to remove the mundane job of data management inside hospitals. And these are very cost effective devices. Something which will help the nurses, these things, and doctor can keep on advising from home. There's so much of paperwork is gone, and you can get a complete electronic records for every drip given to a patient. And cannula blockage is a major challenge. So this is how, madam, IoT will completely change the management of healthcare within IPD also. And you have wearables, that is a very small part of it, but it's going much beyond that.
So Sir was talking in the morning about Northeast challenges healthcare is facing. Same way, remote connectivity. If we have a 5G network, stable network across Northeast, we can even have a remote session. Sir was explaining the situation he had faced. With a proper 5G, today it's there in a lot of the Northeast, but still expansion of the network is required. He could have been able to do a complete remote connectivity with a remote doctor in Guwahati and have some at least insights initially. So at Sir's level that was possible, but on the remote actual on ground, the villagers, that's something we need to talk about, and we need to plan that how technology or a 5G as a network enables that. There are remote ambulances which are being deployed at various villages, government is planning. Those will definitely help, and technology as a 5G which has all those feature sets which allows the capability would play a key role in that part. Next. So these slides talk about a very high level 5G network in terms of the healthcare ecosystem. On the right side, it's all about standard 5G. I won't move into the technical parts, but on the left side, if I talk about the medicine, telemedicine, a remote consultation is possible. IoT, which Anandji talked about, a patient can wear a wearables, which constantly monitors the reports and sends out the reports to the automated systems, and alerts can be sent out to nurses and doctors real time. In terms of if MRI or any other reports is done, it can instantly be sent out to doctor for any alerts, for any quick response which is required. That requires a stable network which 5G provides. And then it's ambulance, remote ambulance over 5G network we have spoken about. In terms of your high definition video consultancy we have spoken about, inventory and asset tracking is something. So inventory management in a healthcare ecosystem is very important. If I talk about EKG machines, which is movable from one place to another, where it's lying at that point of given point of time, that something like that needs to be quickly tracked. There is ecosystem enabled with IoT platform with 5G, which enables the complete tracking of the system. We'll talk about further in the details in the next slide. Surveillance and monitoring. So now if we have to set up a complete surveillance, which is more like a video analytics, we need to deploy multiple cameras. But setting up the camera, cabling, power setups of each camera is very hard task. So today when we talk about geofencing and the surveillance monitoring with analytics, typically 5G cameras, which you power up and just deploy, and they are connected over the network, the private 5G network, and you would have that access to the network itself. Then wearable IoT devices, then data management through platforms and alerts in case the system allows a remote alert over wireless networks is possible. Next. So before that, in terms of another thing, when we talk to hospitals, currently there is no coverage in the hospital. How private 5G, when we talk about private 5G, data plays a key role, but again, voice is still a solution which is required for doctor to communicate to nurses without a network. So when you set up a private network within a hospital, you enable even voice data and messaging seamlessly within the same environment, same hospital, same connectivity, and you control the entire network. You don't rely on Airtel Jio. You don't have to pay Airtel and Jio SIM cards for the subscription. You have your own private network, which allows you to have set up the complete connectivity between the doctors and nurses.
One advantage that 5G gave, I find that hospital is a very sensitive place. You can't allow people to take videos everywhere. So in this network, I can put controls, like director can go and do anything on phone. Some people can only call. Some people can call and give text. Some people cannot take video at all. Because patient data is of sacrosanct. One of the levels of privacy is that it has to control. You can't allow, operations to people by any unauthorized person. You can't allow some people to go into some areas of the hospital. This gives you total control. The hospital, that's required. 4G network will not, by design, does not allow that. 5G allows me that in a complex and defined when we are working. Wet areas, it's very difficult. It should not, nobody should be out there. So if a tanker driver is trying to go and take a film somewhere, we know this is not allowed. It's blocked. That level of access and control, 4G will never be, only 5G.
In-building navigation is another part of the network ecosystem which is required in healthcare or many industries. So today's the hospitals are very large. I can give a personal example. In India, in North, there are very, very large hospitals, and you go visit a OPD and then he says, go and get this test done. Moving from one building to another and finding and talking to 10 people on the way in itself is a very complex task. And I think everybody must have been gone through that phase. So in-building navigation is a very key feature which needs to be deployed across the hospital. Some of the hospital nowadays, what have done, they've done the layout taping across the floor that from this way, this is the path you should follow. But that's still not, people are still not liking it. So QR code or something, automated app, you just open the app for that hospital, it will show you where you are, and from if you need to go and get your MRI done, where you can get the MRI.
So I'll give an example of AIMS Guwahati. Let's say I enter and I come to your room or your building, a retail building. And then every part of the hospital will put a QR code. I have to just download the AIMS app and I open up the QR code there. I scan it. It tells me where I'm standing and then I can speak or I can write where I want to go. We'll draw a map that in 5 minutes you'll be here. It will guide you exactly. Because not everybody can speak to everybody. Hospitals do not have good signage at all. No hospital in India has good signage. Whether it's AIMS, Guwahati or anywhere. It should be made friendly. We are saying is that no matter what language I speak, I may not be able to know to read English, but if I speak in my language, it will tell me. Especially when people come from villages, it's a big pain for them to go and find the right place. They should not be wasting 2 hours just to getting OPD home or a biochemistry section or radiology section. It helps you to do it. And you also know who's moving there, how many people are there. Because once they have scanned it, you know exactly the authorized to go there or not.
So multilingual platform, which Anand just spoke about, enables many languages seamlessly. Next. This is the same thing. Next. So now once you have set up a network across for navigation, the same solution can also enable asset tracking. Each asset will label it as a mark that this is the asset, this is the tag ID. In real time, we can track which asset is lying where. And we can, even in the system platform, you can enter various details, like when the AMC is expiring, when it was purchased, the bills and other information. So you have a real-time tracking. And automatically system would alarm that next month the AMC is due, next year the AMC is due. So you have prior time to get that work done and get all the records in order. So that recording, tracking, everything is there. Along with that, employee tracking can also be a part of it. We can have a small tag with the ID card and we can note, the system can tell you that who's where at what time. And if somebody needs to be pinged or find out, when network is there, they can easily be found out.
I'll give an example of what happened in Ramana Loya in Delhi. Delhi, you get patients from outside also. Two things I was able to do some analysis and tell them as over there. One is that your OPD system, you have a specific time of registration in the morning, let's say 8 to 10, and then only those patients examined OPD that day. Doctors were still beyond 12, 3 for the examining patients. Somebody was going and playing the system and charging money from people from outside. On the same registration number, used to change and then print a new OPD card. Secondly, all your inventory. Every hospital, as a MS, you have limited time, you can't go and track everything. While there are things which are piled up somewhere, you go for a fresh purchase. It should not happen. Substitution of assets should not happen. If you have brought a product A, if it is there for a long time, there are enough. No. Sometimes it happens in the system that somebody will sell the original thing, put a substitute thing over there. Those kind of things you can put exact to this and they are combined.
And the beauty of the solutions we are talking about, they all have open interfaces. So even if you have a third party system today or in future, they can seamlessly integrate it to a solution which will already have deployed the integration part, or in future, because all the future solutions would have the open interface. So integration of the system, be it 5G network or the navigations or tracking systems, is seamlessly connected with any other solutions. Something like the sort a large solution comes into play in the future, that can be seamlessly integrated. So today's all the solutions comes with a built-in interfaces which allows or doesn't become a silo solution which becomes redundant in next few years. Okay. So today we know all the reports are about digitization, big files, huge data center really needs to be required. Then again, data privacy laws, the Indian Data Protection 2023 law. Next. So I'll touch base about the CDN. So when we talk about private 5G, we know that it's a high throughput, high speed. But again, when the files are 1 Gbps, 2 Gbps, you can't have real-time downloads of data every time. That's where this CDN, content delivery network, comes into play. So typically, if here we are 10 guys.
So that's simply so you must understand what CDN. Every year when 10th and 12th results are announced by CBSE, kids go to CBSE website, it crashes. Every year you find the same news item. All of us have witnessed that. Because across India, everybody is taking the data server in Delhi, it has got a capacity, it crash. And same it has been accessed. So if there are, another example, if you have got, let's say 10 SR, 100 JRs in hospital, you go there and okay, you take this particular classes online, download the video to study. If let's say I'm a student and I want to go and see a video on battery therapy, and there are 50 more colleagues of mine, so they will 50 times they'll go to the same server, download, your bandwidth is gone, finished. Your internet consumption is finished. Same data is downloading and again. What a CDN does is that it's a smart thing. Moment that class or that content is downloaded from the main server, it is stored in local cache in your AIMS devices. From second to nth student, you need download the things only locally. So your main highway is still free. You're not wasting bandwidth. That is the beauty of it. Will happen. So because that imaging will be seen by surgery also, anesthesia also, multiple departments will see. Why should they waste the main bandwidth? So CDN allows party. And it's a very simple term. When you see Netflix, it's not in Bombay. Wherever the consumers are putting small cache servers. So one day prior to a new series being launched, they will download and put it in the server. So when you start, instantly you can see the video. So that's what we are proposing. That because tomorrow we establish a network of medical colleges, CME platform or data sharing platform for within or outside the hospital, you should have a CDN. Once it is stored locally. Same data, if 100 students are saying, why should I waste my internet? You pay more for the internet bill, more for the server storage. It's not required. This is CDN. So currently, most of the data is in big cities. So your bill travels from northeast, all the places here again and back. So buffering time, congestion, more and more internet bill. We reverse this CDN of the government.
Yes, so CBSE are yet to learn this.
Sir, CBSE
are
because you have to, our Policy makers don't know the importance of digital economy, digital traffic.
Their nodal officers, all of
Sir, I'm very disappointed by NIC. Very disappointed because dumping of technology is taking place. You are not taking it in a time when you have iPhone 16. If I'm going and buying iPhone 9 or 8, it's criminal because it will become redundant. It will become redundant. You have the latest platform. Again is there, and with this it gives you a basic cost also. It's a different cost. Every cost will come down. I can show you in Manipur Secretariat that 40 internet connections not required. With CGN, I can control everything on a smart network. What's my annual bandwidth consumption? I think government officers in Shakti Mundra is wasting internet and downloading movies. The boss is not there. Whole time they are downloading movies. CDN helps you to control a lot of those kind of misuse.
Just to add that even in Northeast, if there are interconnected hospitals, AIM Guwahati is connected with each hospital, main hospital in other states, and somebody gets a report done, test done at Guwahati. He goes back and he asks that let me download that report from AIMS Guwahati. That download time would be such that they'll say, okay, get me the hard copy. That the system becomes useless. What would happen in the next slide? So typically in that case, system would automatically check that this is the file. Typically, I would need to be sent out. This user is from Meghalaya. The system, the caching system enabled with analytics would push that report pre-hand to the Meghalaya ad server itself. And whenever the doctor at the Meghalaya needs to view, he'll get download it pretty fast. So that the time difference of download from the hub versus at the local download enables the system to be used seamlessly and in a better, efficient manner. So again, like Anandji pointed out, fast delivery and then cost and reliability. This enables a lot of cost saving. Sugaji talked about green network and how it enables carbon footprints. So all those parts are.
Sir, I spoke about today multiple movement of CDs or CT scan for cancer patients. It can stop here. If I want a tumor board to sit from different states together on a particular case patient, one download everywhere. System will push automatically. We have ID of doctors, we have their node number, system will push. Why should a person travel all the time? And in Keegan, what I have proposed on PM1 exactly this model for entire hospital that you connect two names, everybody into the CDN network. And if I have got 10 CT scans to the patient, we'll show auto regression of progression of cancer. Tumor board takes a lot of time. I know what's happening in DBPI. There's a lot of congestion and decision making. Those things, mundane things, have to go away from paperwork to automated process.
And on top of it, the way 5G network, let's assume a hospital is private 5G and you deploy a CDN network. The technically private 5G with MAC, multi-access edge computing, talks to CDN servers. So over the 5G network also there is caching happening. So CDN downloads it the local edge and the 5G network itself downloads through CDN edge servers to the network. So users or the private 5G users with the CDN edge server would have a very seamless downloads for those reports or any other data. That enables a very fast and a quick download for all the information required with 5G and the CDN network deployed. So then this is next slide. This is the CME, continuing medical education. So I know Dr. Yadav and have spoken a lot about it. The solution is more about integrating the faculties, the doctors, sharing information, which is covered in detail by Dr. Manu and Dr. Yadav. So I think we can skip that part. Thank you.
Thank you so much, sir. I hope a lot of healthcare can get this benefit of 5G. Thank you so much, everyone. So this is end of the day, and let's meet tomorrow for more such insightful sessions. Have a good day.
Nada.
Chakravarti. So, Sir Lauru sir, can you do the favor?